Dr. Krishna Kumar, Dr. Anil, Dr. Archana, and all the esteemed members of this audience. First of all, I would fail as a human if I don't thank NOTTO for setting this up. Something close to my heart, that is to spread the word about deceased donor organ transplantation program to everybody. I always believe that the greatest stumbling block for organ donation, harvesting from brain donors, is definitely our community, that is doctors. And the biggest culprits are, of course, neurosurgeons, who refuse to admit to themselves as well as to their relatives, patients, families, that they're a patient, that the patient who is now on ventilator without any brainstem signs is actually brain dead and not going to come back. This way, as I said earlier, a lot of resources are used in the most futile manner. My attempt has been in the last 11 years in certifying brain deaths has been to reduce this and improve the donation from deceased donors so that there will be a lot of lives happening from somebody who is not going to live. Let me begin with a disclaimer. I know very little about death. I know very little about death because I haven't experienced it myself. But in the last 11 years, I've been doing a lot of certifications. Let me just begin with a definition of death. Whenever we need a definition, we look forward to the white man. But then, in plain English, death means loss of capacity for consciousness and the loss of capacity for breathing. This is in simple English. Okay. Now, if that is not there, then you can say that a person is dead. Okay. Now, there is an interesting science called thanatology, which is actually the study of death. But this also includes care of terminally ill and as well as care of family members of a dying person. So, as a doctor, when I passed out in the 90s from Trivandrum Medical College, there was only one way of dying, and that was the cardiopulmonary arrest. Every death certificate will have cardiopulmonary arrest written on it, which is actually wrong. There are the other reasons should be mentioned, but the last event is always the cardiopulmonary arrest. When I was passing out in the mid-90s, there were only 2 ventilators in the whole hospital. So we did not know what brain that was. Subsequently, we started to see a lot of changes in the care of patients who are ill with brain strokes, and that's when brain death came into our jargon. Now, I just want to go back to what is brain death. Brainstem death, as you call it, that is the correct word. Brainstem death means your midbrain pons and medulla are no longer working. And when midbrain pons and medulla are not working, the supratentorial brain also is not working because the pneumotaxic center, the apneistic center, etc., located in the pons in the midbrain are not working. Now, let me come to the actual definition of brain. This is again in plain English. Brainstem death occurs after a neurological injury. Underlying the fact that it's a neurological injury when the brainstem has been irreversibly damaged, but the heart is still beating and the body is kept alive on a ventilator. This is again a simple definition of brainstem death. Okay. Now, when do you call it brain death? Again, coma, whereas there is a failure in responding to external stimuli, and 2, absence of brainstem reflexes as evident on clinical testing. And last but not the least, apnea test, which means, apnea, not apnea test, apnea, which means that the respiration is supported by a ventilator. Okay. Now, what has changed in the last 2 decades is a lot of resuscitation is happening, and ventilators and support gadgetry. Post-COVID, every hospital in India has been abundantly supplied with ventilators, and they are being put into good use by critical care experts. Intensive care was not there in the 90s. Post-2000, a lot of critical care specialists have moved into our country, and they're making a difference to a lot of patients. But in the process, they're also creating a few patients who are not dead, nor are they coming back to life. So that's why we need to declare brain deaths. Hook up a patient on a ventilator, keep him there alive when you know that he is not alive. Only his heart is beating and other kidneys and other organs, visceral organs are functioning, but he's not going to come back into life. That's when you should go for organ transplant. Now, as a neurosurgeon, I encounter a lot of patients with brain, but most of the times, the causes of a brainstem failure is hanging and resuscitation. I'm sure you must have encountered this in your emergency room, cardiac arrest and resuscitation, brain hemorrhages, especially intracerebral hematomas and subarachnoid hemorrhages, which lead to irreversible loss of brain function. Strokes, we are a country where the population is aging. We are in, and also a diabetic capital of the world. All this means there are more infarctions, brain infarctions happening, which means that there are more brain deaths happening. Uh, Brain tumors, well, there is definitely an increase in number of brain tumors that are reporting to the hospital. Many attribute it to things like mobile phone and all. We don't have evidence for that. But what is happening is there is more of screening with CT scans and MRIs, which detects a lot of brain tumors, some of which are detected very late or they end up dying during surgery. All that leads to the pool of patients who end up on ventilator brain death. Last but not the least, India is also the accident capital of the world. We have more road traffic accidents than in probably many other parts of the world, which means that many young people end up being brain dead in an ICU. Now, when we look at coma as such, we need to look at the mimics of coma. I cannot forget this because I'm basically a neuroscience person. So the first thing is locked in state, which is actually a state of quadriplegia. The patient is alive and well. The vertical eye movements are present. This happens in Ponting infarct. So the extraocular movements needs to be tested on a patient who is hooked on a ventilator, not being able to move quadriplegic. The second is a state called as persistent vegetative state, where there is absence of responsiveness and awareness due to overwhelming dysfunction of the cerebral hemispheres, but with sufficient sparing of the midbrain and brainstem to preserve autonomic motor reflexes and sleep-wake cycles. A perfect example of this a person in a persistent vegetative state was this lady called as Aruna Shanbog. Aruna Shanbog was a young 20-something old nurse in KEM Medical Hospital in Mumbai in the 1970s. She went to change into her uniforms, nursing uniform, in the basement of the hospital, and there was an attempt to rape her, and she ended up being strangulated by a dog chain. The dogs were kept there for physiological experiments. She didn't end up dying. She ended up having a hypoxic brain injury, which made her in a persistent vegetative state. Aruna continued to be in the care of the staff nurses and doctors of the KEM hospital for several years, close to over 40 years. She died about 4 years ago. This was that she did not need a ventilator, but she was kind of in not responding to anything. Only thing is there was little bit of respiration and other functions happening in her body. Third, of course, is the minimally conscious state. Unlike a vegetative state, is characterized by some evidence of awareness of self and environment, and these patients tend to improve. These are the common mimics which you need to be aware of. Now, we also need to rule out the reversible coma-inducing states. One is, of course, brainstem encephalitis. The second is the Guillain-Barré syndrome, or the encephalopathy associated with hepatic failure, uremia, and hyperosmolar coma. These are kind of checklists which you need to run in when you're declaring brain deaths. Okay. In Kerala, once a case was there when a patient was, the doctors were accused of keeping the patient on depressant drugs and declaring him as brain dead. So we need to rule out, though it was not wrong, right, we had a tough time trying to extricate ourselves from this case. So the important thing is you need to period of observation of that approximately 5 times the elimination of half-life of the agent involved. The most important agent, which is a long-term, long duration time for excretion from the human body metabolism, is thiopentone. So you need to wait up 3 to 5 days sometimes for the thiopentone to get discharged from the body, from the fat stores where it is stored. You can also try specific antagonists like flumecin and naloxone in specific situations. And it's also important when if you suspect that there is a toxin present, there is a depressant toxin present, to sedative present, you must go in for a plasma analysis if it is available. Now, it was about 10 years ago, Atul Gawande, a neurosurgeon of Indian origin in the US, came up with a book called The Checklist Manifesto. We all use checklist everywhere. All the surgeons use a WHO checklist before they put the knife on a patient. So I also have a checklist before I start the brain death declaration. First is, of course, coma with ventilator support. Is it there or not? The cause of the coma should be evident on the CT scans and other investigations that are present. No CNS depressants. As I said earlier, you wait for all the depressant drugs to wear off before you can take the patient for a brainstem death declaration. No metabolic anomalies, especially hyperglycemia, uremia, hepatic encephalopathy, etc. And the temperature also should be normal. So this checklist you need to run before you start brain death certification. What are the actual neurological tests that you do to confirm brain death? First is, of course, the common pupillary reflex. You shine a torch after dimming the lights in the ICU and find out if the pupils are reacting. The second is the corneal and the conjunctival reflex, where you touch the cornea and conjunctiva with a wisp of cotton. You just see the blinking reflex is present or not. The third thing is a doll's eye, where you move the patient's head from side to side. But before you do that, you ensure that there are no cervical spine injuries, nor is the patient having any significant cervical spondylosis, so that you can inadvertently cause quadriplegia. The gag and cough reflex, the gag reflex is done by stimulating the posterior pharyngeal wall. Using a tongue depressant, you depress the tongue and then go in for the posterior pharyngeal wall and touch it. If there is a gag reflex, there will always be movement of the pharyngeal wall. Cough reflex is done by introducing a suction cannula through the endotracheal tube or the tracheostomy tube into the trachea, and then finding out if there is a cough reflex along with that. Painful stimulation can be given on the area around the brow of your eye and also over the chest to find out if there is any response to pain. And last but not the least, the calorie tests, which are done by instilling cold water by raising the patient's head to about 30 degrees, instilling cold. And before you do the calorie test, always inspect the eardrum, whether it is perforated or not. And then pour some 20 to 50 ml of cold saline into the ear and keep the eyes open to watch for any nystagmus movements or correction that happens after that. So these are the basic neurological tests that have been done as first line to confirm brain death. Now, in a case when you just have to ordinarily declare a person as brain dead, these tests are enough. But if you're going in for a patient for organ donation, we need to bring in the apnea test also. So what is the apnea test? Apnea test is simply you're trying to trigger the brainstem into action, kick the brainstem into action by raising the carbon dioxide, partial pressure of carbon dioxide. Now, for that, you have to remove the patient from ventilator for a brief amount of time. What you have to do is you have to pre-oxygenate the patient with 100% oxygen for 10 minutes, and then you send a baseline ABG. The baseline ABG will be around 35 to 45 millimeters of mercury of PCO2. And then, once you have done that, disconnect the ventilator, deliver oxygen at the rate of 6 liters per minute through an intratracheal cannula, and watch for any respiratory effort. So the duration of this disconnection is from the ventilator is about 10 minutes for 10 minutes. I usually draw an ABG by the 8th minute and the 10th minute, so that if the partial pressure of oxygen of carbon dioxide is more, it means that, and then there is no respiratory effort, it means that the patient is irreversibly brain dead. Now, when do you abort an apnea test? When there is a precipitous fall in blood pressure, when there is a fall in oxygen saturation, or the appearance of a cardiac arrhythmia. These three situations, you have to abort the apnea test. Usually, this may not be required. In over the 100 plus tests that I have done, brainstem determinations that I have done, I had to abort the apnea test only once, but that was because the patient was already had a precarious hemodynamic status following a subarachnoid hemorrhage. Now, how do we interpret the apnea test? An apnea test is positive if you have raised the carbon dioxide by 20 millimeters of mercury, or the PCO2 goes up to 60 millimeters of mercury, but then there is no respiratory response. So the positive response is no respiration. So that's how you interpret the apnea test. The second is it is negative if there is no respiratory response. So a positive apnea test means the patient is irreversibly brain dead. And Negative means if the respiratory movements are seen. Yeah, I'm going to stop. So I'm not going to the ancillary test now because there is a warning from the organizers that one test that I would like to depend on is the CT angiogram or the digital subtraction angiogram, which tells us how blood is flowing through the cerebral vasculature or not. If it is not present, it means that the patient is brain dead. But it can be present spuriously in certain situations when you have a shunt done, when you have a lowered the intracranial pressure with a decompressive craniectomy or an external ventricular drain. Now, the other tests like transcranial Doppler and EEGs are useful, but again, they are very difficult because of certain technical errors that can come in. And radionuclide scans are not possible in India. I just want to speak briefly about Lazarus sign. This is actually an event that happens in a patient who is brain dead when there is spontaneous movement of the arms across the chest. This is actually a spinal reflex. This is actually a red herring, which means it is mistaken as a sign of life. But this is based on a character called Lazarus from the Old Testament of Jesus Christ when he was resuscitated by Jesus from death. Okay, who can certify it? It's usually a 4-member team according to the TOTA Act. One is a treating doctor. Second is the RMO, Resident Medical Officer, bar medical superintendent. And third is 2 members from the panel of doctors, neurologists, which includes neurologists, neurosurgeons, and intensivists, formed by the appropriate authority for the same. How does it help? When a person dies, brain dead, and then donates, his 2 kidneys go, his liver goes, his cornea goes, his pancreas goes, his hands goes, and his lungs goes. Close to 10 people are benefited. That is exactly the difference that you can make from a single organ donor. So remember, every time when you declare somebody as brain dead and do not allow the organ donation to happen, you're actually hurting the lives of more than 10 people. I think I'll stop here. Okay, let me come to the last slide. Brain death or brainstem death is defined as a state in which there is absence of neurological response. Excuse me. And absence of neurological response as confirmed by brainstem reflexes, absence of brainstem reflexes, and a respiratory failure supported by ventilator. Testing involves neurological tests as well as followed by an apnea test. Ancillary tests can be useful when there are doubts or indeterminate status of the clinical testing. And last but not the least, there is always delight in death, and that happens when you help the living. Thank you very much for your patience.
So we will take questions a little later. I would like to thank sir for his kind address, and I would also request Dr. Krishnan Kumar sir to please come up on the stage to felicitate sir for his address. Can we have the projector turned off for 5 minutes, please? Projector room, please switch off the projector for 5 minutes.
कोशिश करती पूरा स्टेज कवर हो रहा है इसलिए आ जाता है बीच में ये बंद कराओ अगर अभी प्रोजेक्ट नहीं चल रहा इसको बंद कर दो ये साइड वाला पोडियम
लेक्चर इसके बाद में तुरंत
यस सर
क्या आप इसमें
सर इसमें लोग
बाद में करेंगे
सर तभी हो जाएगा खत्म मैम करेंगे मैम कर देंगे थोड़ा व्यू आ रहा है नाटक होगा सर, मैं फोटोज की, हाँ फोटोज ले लेना उससे, इसलिए अवेयरनेस करेगा ना। इससे नहीं होंगी फोटोज, लिमिटेड होंगी। नहीं तो मेरे फोन की कैमरा अच्छा नहीं है, मीनाक्षी से ले लो, मीनाक्षी के फोन में अच्छा है।
Lights on. Stage lights.
अलग-अलग स्ट्रीट लाइट्स किसी बंद करना है, अभी 20 साल से कोई रिकॉर्ड है।
लेकिन सर
मल्टीपल लाइट्स चाहिए।
लेकिन सर आप लाइव स्ट्रीम करोगे ना, बात लाइव स्ट्रीम तो ऐसे ही समझ आएगा।
नमस्कार। टैगोर इंटरनेशनल स्कूल बसंत विहार की नाट्य संस्था टीम अवाम प्रस्तुत करती है आपके सामने अपना स्वरचित स्वनिर्देशित नाटक एहसास।
चित्रगुप्त
सर sorry sir I'm late. Sir if you don't mind me asking आपका मुकुट भूल गए क्या? आगे हो जाओ।
मुकुट हम भूले नहीं है, ये सब तो हमारे ही रूप है, हमें अकेले मुकुट पहनना शोभा नहीं देता ना।
सॉरी सर सॉरी मैं apologize।
कहाँ पर आए?
हाँ जी
आपकी तारीफ
जितनी की जाए कम है। ये रिप्रेजेंटेटिव ऑफ भगवान है, इनका रिकॉर्ड कहता है कि सारी उम्र भक्ति में गुजार दी, अपने और अपने परिवार की जिंदगी संवार दी।
इसकी चेकिंग करवाई?
नहीं सर, अभी तो प्रोसेस स्टार्ट होने को है, पर्दा पास होने को है। What are you waiting for? मुहूर्त। आंखें हैं, लिवर भी है,
इसकी 2 किडनीज
दोनों की दोनों है, हार्ट और लंग्स भी है। अरे यार,
ओ माय गॉड, मी
ओह नो, ये क्या गोरख धंधा है? हम समझ नहीं पा रहे।
इसे नर्क में डाल दो, सजा दो इसे।
गौर से देखिए इस भाभी को, इसे अपने बाबू की सजा मिलनी चाहिए कि नहीं?
चित्रगुप्त
कंट्रोल बेबी कंट्रोल।
पर प्रभु वाई
आपका नाम जपा एवरी डे, सुबह शाम आपका नाम, सुबह शाम आपका नाम, सुबह शाम आपका नाम।
बस खामोश। बनाया था जब इसे मनुष्य, कुछ सोचा था मैंने, सबके ये काम आएगा, यही चाहा था।
सर्वगुण संपन्न तभी तो बनाया था। इसकी भक्ति सिर्फ दिखावे की थी।
नहीं पहुंची इसकी आवाज मुझ तक कभी।
मुझ तक कभी। Okay, let's take this body to Nana. We'll be right back. टाइम लगाते हैं लोग। Next.
नाम सत्य है, सत्य कितना सत्य है, सत्य में असत्य है, नाम सत्य है।
इसकी भी चेकिंग करवा लेते हैं, प्रभु का टाइम बचेगा ना।
स्मार्ट साइमन स्मार्ट।
देखो वो तो मैं हूं ही ना। आंखें नहीं है इसकी।
लिवर तो चेक करो।
लिवर भी नहीं है।
दोनों किडनीज
भी नहीं है। क्या बात है।
और भैया हार्ट?
एक सेकेंड, हार्ट भी मिसिंग है।
रुलाएगा क्या? बस ये सजा का नहीं, ये इनाम का हकदार है। इसे स्वर्ग लेके जाना है, सारी अप्सराओं से इसका इंट्रोडक्शन कराना है।
कंट्रोल चित्रू कंट्रोल।
कंट्रोलिंग
पर प्रभु इससे इतनी इम्पोर्टेंस क्यों? आपकी पहचान वाला है क्या?
ये मेरी पहचान वाला नहीं है, मेरी पहचान है।
प्रभु का रूप है, प्रभु का गुण है, प्रभु का रूप है, प्रभु का गुण है।
मृत्यु से पूर्व कराया इस अपना हर एक अंगदान। प्रभु के पास आना है सबको एक ना एक दिन।
ये जीवन का अटल सत्य है।
पर आने से पूर्व
यदि करवाओगे अपना हर एक अंगदान,
तभी तो अमर हो जाओगे मेरी जान।
प्रभु एक तो क्वेश्चन आया है।
आने दो।
आने दो, आने दो, आने दो, आने दो।
आने दो।
अगर करवाएंगे हम अपना अंगदान तो भैया मोक्ष कैसे मिलेगा?
मोक्ष? किस मोक्ष की बात करता है तू? हाँ,
अपने स्वार्थ के लिए बनाए उन नियमों का।
अरे मूर्ख, चल चल तुझे कुछ दिखाते हैं।
एक सत्य का दर्श कराते हैं।
इंसान का शरीर मानो गॉड मेड मशीन है।
मैंने बनाया, मैंने।
यदि कोई अंग साथ छोड़ दे तो उसे रिप्लेस किया जा सकता है।
रिप्लेसमेंट कराने को तो हम तैयार हैं, मगर आप थोड़ा एक्सप्लेन कर देते तो। यू नो व्हाट आई मीन।
आई नो व्हाट यू मीन। मृत्यु के बाद ऑर्गन डोनेट किए जा सकते हैं।
अगर 4 डॉक्टर्स कर दे सर्टिफाई।
दिमाग साथ छोड़ दे।
लेकिन फिर भी
खून का दौरा जारी है तो ऑर्गन का दान किया जा सकता है।
प्रभु एक तो क्वेश्चन और आया है।
आने दो।
आने दो, आने दो,
आने दे भाई।
आने दो।
हमारे शरीर में तो इतने सारे अंग हैं, तो दान कौन सा करे?
बताओ भाई, बताओ।
लंग्स कर सकते हैं आप अपने।
लिवर,
2 आईज।
पैंक्रियास।
और आइंस्टाइन तो भैया मुझे भी पता है।
आइंस्टाइन नहीं होता है, इट्स इंटेस्टाइन। इंटेस्टाइन।
कोई बात नहीं। शाबाश शाबाश मेरे अपना इधर। हाँ।
अगर कोई इंसान करवाए अपना हर अंगदान
तो बच सकती है भैया 10 से ज्यादा लोगों की जान।
एक डोनर 10 रेसिपिएंट।
हो हो हो, बहुत इंसाफी है। अरे रे, पिक्चर तो अभी बाकी है मेरे दोस्त। ऑर्गन्स के साथ टिश्यूज भी डोनेट किया जा सकता है।
पर कैसे?
2 आईज,
1 हार्ट, स्किन, बोन, लिगामेंट। मर कर भी अमर हो जाओ,
अपनी मृत्यु को सुमृत्यु बनाओ।
आपसे चाहते हैं वादा, केवल इतना।
इंसान हो
तो इंसान बनकर दिखाओ।
मर कर भी अमर हो जाओ, अपनी मृत्यु को सुमृत्यु बनाओ।
तो देखा आप सबने, आपका, हमारा, हम सबका एक छोटा सा एहसास कितना बड़ा बदलाव ला सकता है। आज उसी बदलाव का हमें साक्षी बनना है।
आज, अभी, यही,
Right now।
हमें ऑर्गन डोनेशन का प्रण लेना है।
प्रण ले लिया हो तो बता दीजिए। एक बार जरा जोर से ताली ही बजा दीजिए।
Thank you so much, NSMC and NOTTO, for giving us this opportunity to perform here. Thank you so much, everybody. Thank you so much for that mesmerizing performance, students of Tagore International School. With this, we move forward to our next address by Dr. Deepak Gupta. Sir is going to address us on the protocols of brainstem death in cases and challenges. He is a PhD from IIT Delhi, AIIMS Delhi, on FEA biomechanics of craniovertebral junction. Sir is currently interested in the areas of pediatric neurosurgery, neurotrauma, etc. We welcome you, sir.
नमस्कार एंड वेरी गुड मॉर्निंग। आई ऑलवेज वंडर कि हम लोग जिस लेक्चर को लेने में 20 मिनट लगाते हैं, ये छोटे बच्चे 3-4 मिनट में इतना स्ट्रॉन्ग मैसेज देके चले हैं। Anyhow, this is a very proud moment for me because I'm a product of this place. I'm a Hardonian. I did my MS from here, then I was here as a senior resident. And I must confess here, I took my first lecture on stage ever in my life on this very platform way back in 1998. And those days we used to make those slides and we have to go to INA to make those slides and then make presentations. So it's almost like 25 years down the line. I'm back here at this podium. It's a very proud moment for me, I must say. Can I have a raise of hands? How many are the doctors dealing with the ICU patients here at the back? I'm not interested in the front row people. I'm interested in the people at the back. You are the building blocks, and I look forward to you. How many neurosurgeons here? Doesn't matter. How many intensivists? Quite a big number. So I think I will be able to justify my talk a little bit. I think Ishwar has already talked about the brain stem death certification issues in the adults. My talk will be more of a reinforcement of what he has already talked. In fact, I was discussing with Ishwar yesterday. You're talking about adult, mine is children, they all are same. I shared my slides with him, but then there is no duplication of anything, it's just a reinforcement of what he has actually just told you. This talk is dedicated to this little girl, Roli, and I use the word Roli effect on India, I would say, because we made a very humble beginning at AIMS Trauma Center in pediatric donations, and after Roli, we have had total of 5 pediatric donations in children as young as 16 months of age. This is a cascade of children who are coming to us. In fact, you'll be very surprised. There is something called as a fall from height. It is something so common in our country, you won't even believe me. In the other part of the world, this injury pattern is never seen. Every day in the ICU, Paneet is there with me. We've got 1 or 2 children coming from fall from height. Every month, we are losing around 3 to 4 children from the head injuries. And so we have begun a campaign called Safe Balcony, Safe Child. We have identified certain parameters. Anyhow, there are certain children whom we cannot save, and it is in them we should be making all efforts to certifying in time and to keep the organs healthy. I must tell you, I've spent almost over 2 decades in AIMS, but this concept of pediatric donation was actually just not existing. People didn't even know whether the children can actually donate organs or not. Trust me, it sounds very foolish and silly, but that is the state of the fact. There are some challenges in the organ donation in the children, especially more so in the neonates or the infants, both for the transplant surgeon also, because the organs are very small. So many times, many of the people, they don't even know what is the logic. We have heard a child, 24-day-old child donated his organs. 1-day-old child donated his organs. But what organs will you accept from the child? Will it be heart? Will it be kidney? And how useful they will be like? So those are the doubts in the mind of the retrieval team and the transplant team, which should be clear. See, whatever activity you are doing, आप जो भी कुछ कर रहे हो, you should have a logic or some explanation. कुछ उसका फायदा होना चाहिए. Otherwise, it makes no sense. So I was very happy to see all the 4 children which were acknowledged by NOTTO on 14th of November, this Children's Day. They came from AIMS Trauma Center. And with me, our assistant professor, Dr. Popula Paneet is there. He has been my backbone. Actually, we have been doing all the donations thanks to him. I'm just the face. He's the man who's working all the time. So these are the 4 cute children whom we lost in a span of just 5 months. And they actually donated their organs, giving a very strong message to the people that children of such young age can donate. Why can't the adults do that? As Ishwar rightly pointed out in his talk, we are a factory of road traffic accidents. It's quite unfortunate, but India is probably the only nation in the world where over 95% of the organs, they come from the head injury patients. Rest all nations, you go to Spain, Italy or other places, the organ donors, they come from hypoxic brain damage, donation after cardiac death, not from the head trauma. Head trauma is the only thing in our country. 150,000 deaths, 1.5 lakh लोगों की मृत्यु होती है head injuries in our country. How many donations we have? 700. We heard in one of the presentations, we are 3rd in the world in the organ donation. Actually, when we talk about the deceased donations, yes, we are 3rd in the world, but we are 3rd in the world from the bottom, not from the top. Not more than 700 to 800 organ donations are happening from the traumatic brain injury patients in our country, despite almost 200,000 deaths every year. People do not even know even the brain tumor patients, grade 1, type 1 and type 2 WHO, stage 1, they can donate organs. People are not even aware of in our country. You talk to the neurosurgeons, even they do not know about it. So there's so much of, I was hearing in the morning, somebody said that it's a lack of awareness in the clinician which needs to be addressed. And there's so many clinicians here. It is where I'm going to base my talk on. So there was a very interesting survey carried out in many of the pediatric intensive care units, almost 145 units, and they found 20% of the death were actually brain deaths, because nobody knows if the children actually die of the brain death or the cardiac death. But when you start looking for it, then you understand almost 20% of the deaths in the pediatric intensive care units you can pick up as brain deaths and a potential donor. Now, this slide is extremely important and interesting, and it is where the role of the neurosurgeon comes, for the people who are dealing with the organ donation day in and day out. You have to understand what happens when there is a herniation. We have a brainstem, so-called midbrain, pons, medulla, and it herniates. There is ischemia. So when the ischemia travels from the midbrain to the pons to the medulla, specific things happen, and that's the beauty which you need to understand. At each and every stage, a specific changes take place in the heart rate and the blood pressure. The last stage, if you see very carefully, the patient will have drop in the heart rate and the blood pressure. But somewhere in the intermittent stage of medullary ischemia, you have got Cushing's response. All of you must have read in your residency schools, Cushing's response, Cushing response. But when the Cushing response actually disappears, it is where the person enters into a brain death stage. So I tell everybody, any patient who is having a normal blood pressure, he is not brain dead, period. So a person who is brain dead, he has to be at least on one single vasopressor. He will not be able to maintain his temperature. Any person who is not maintaining his temperature or hypothermic is very likely to be brain dead. Any patient who is producing large amount of urine, so-called diabetes insipidus, is likely to be brain dead. Any person who is hypotensive on at least one vasopressor is likely to be brain dead. So, you as a clinician, when you visit your ICU, so many times it happens, faculties come and take the rounds in the ICU. Patient is GCS 3/15, people fixed dilated period, bed number 2. Resident को भी अच्छा लगता है, ज़्यादा कुछ बताना नहीं पड़ता. You don't have to tell too much about the patient's prognosis and what else has been done. But the irony of the state is, trust me, I have visited few centers in our country, I will not name them, where patients develop rigor mortis in the ICU. Rigor mortis I'm talking about, without any brain death being diagnosed. And this I'm talking about the country's best academic institutes with the best neurosurgical facilities in the country. It happens. It is because people are not interested, they don't have any vision. So the moment you see a patient who is having a hypotension, hypothermia, diabetes insipidus requiring some vasopressor support, strongly suspect this person could be brain dead, whether it's an adult or a child. So you have to have a clinical diagnosis, most important. Coma and apnea, they must coexist for a brain death diagnosis to be there. There should be, of course, absence of neurological functions. We'll shortly demonstrate sometime, and Dr. Ishwar will join me for that. Now, what is unique is that in children, these tests have to be performed in the setting of a normal age-appropriate physiological parameters. By this, I mean specifically about the blood pressure. In an adult, you want blood pressure to be slightly higher, but if you have a child who's 6 months of age, you don't have to wait for a systolic blood pressure of 100 before doing the apnea test. So it has to be age-appropriate parameters. There should be a known cause. If you have an unknown patient, unknown mechanism of injury admitted to you, please don't jump or rush to declaring brain death. Your chances of committing errors are quite high. And always remember, if you do 99 good steps or Samaritan acts in brain death declaration, if you do one wrong act, that spoils the entire organ donation program. We have seen very interesting series of movies, let it be Josephine from Malayalam, or The Sacred Heart, and so many other movies. They all talk about the same nonsense. So you need to be extremely careful. The coma should be reversible. There should be complete neurological examination should be done. You have to do pupils, you have to do cornea, you have to do gag, you have to do cuff, you have to do cold color. Each and every step has to be done. If one of the tests is not done, you have to take care of the ancillary test, period. No discussion on that any further. It should be conducted 2 times. And of course, the most important thing, which Dr. Ishwar always talks about, is all components should be appropriately, nicely, and adequately documented. The paperwork is something extremely important when you're doing the brain death certification. You should not falter on that. So these are age-specific parameters. We have latest 2011 pediatric brainstem death declaration guidelines, universal, and they are in place, and anybody could go through that. So basically, why do we do examinations? many of you would have questioned this, like why two? Just one should be enough. So first examination is basically determines the child has met the neurological examination criteria for brain death, and second actually confirms. That is the whole concept behind it. Interval is all subjective. Some people say 12 hours, some people say 24 hours, but by and large, in up to 1 month of age, 24 hours interval, and then up to 12 years, or some people say 18 years, 12 hours interval, and adult 6-hour interval should be there between the tests. Now, it is very uncommon, I would say, if you look at the organ donation statistics from our country, you will see that the children are quite infrequent contributors, though they die equally. Ours is a young nation, 40% are the children. They die very frequently, but they are often missed, especially in the traumatic setup. And of course, we don't have a specialist to certify and to conduct the various tests in the various ICUs. And there are some resistance from the parents initially, I would say. So these are the things one need to exclude, so-called the reversible causes. The serum sodium has to be between 115 to 160. If you look for, conventionally we have been taught, हमें पढ़ाया जाता है कि serum sodium has to be between 135 to 145. Come on, we are talking about a scenario of a brain death. You don't expect a person to have ideal biochemical profile. It will never ever be there. If it is there, that person is very unlikely to be brain dead. So you have to kind of do an expanded criteria for putting up a patient into the brain death certification. So this is how the CT scan looks like. There has to be a damage. We always, me and Paneet, we always look at the CT scan before we jump to any conclusion. There has to be evidence of irreversible damage or hypoxic brain damage or a sign of ischemia, black brain, some white cerebellar sign. That is the first prerequisite in traumatic setup. Then these are the series of tests you have to do. You have to do Coma. The patient should be having a cessation of spontaneous respiration. Again, it's very subjective. So many times I've seen in the ICU. On the ventilator, you have set a rate of 12, but on the monitor, you get a rate of 14, 16 sometimes. And your wise anesthetist or a wise colleague or a wise intensivist or even a neurosurgeon will say, oh, this person is alive. There's a discrepancy of 4. But it is where the ignorance comes into picture. Unless and until you know your ventilator parameter and how to look, what is the control, what is the setting the ventilator is on, what is the trigger the ventilator is on, you will miss out these patients. And what happens if you miss out that patient for that particular half an hour, 5-minute visit you're making, you will go on to the next day. And by the next day, this person will not be there in the ICU. So if you know about something called as a ventilator auto-cycling or rebreathing ventilator and other parameters, you will miss out such patients. You have to know your subject well so that you don't miss out even a single patient. And of course, the apnea test has to be done at the end. The most important thing when you're doing the dorsal movement, you just hold the head and move it on either side. So many times it so happens the endotracheal tube comes out, and it's a disaster in the ICU. You're struggling to intubate another thing. Please hold the endotracheal tube with the hand when you move the patient from side to side. Small steps that you need to be very careful when you're doing this test. Lazarus sign, of course, I don't know how many of you know and how many of actually faced. I have faced it myself. We were doing the putting in the line in a person. We had done the apnea test and everything. Second test, whenever was it done, I got a call from one of my very senior colleagues. DG, what are you doing? This patient is moving the legs. How can you do the brainstem test certification? I said, what nonsense? This person is having a spinal reflex. You try to put in an arterial line from the femoral and some movement, some triple response if you get. Yes, that's a spinal reflex. That's a Lazarus sign. We all know about it. It's still a sign of brain death. To allay the anxiety in such cases, like in that case, we went ahead and did the CT angiogram and demonstrated the absence of cerebral blood flow. So unless and until you know this thing exists, a wrong message gets conveyed to the entire ICU. So the person who's leading the program has to be smart enough. He should read his subject very thoroughly before he takes on the program any further. So I would say apnea test is some test which is the most talked about test. Apnea. But it is the least understood and the least known test. There's so many, ifs and buts of apnea test which all of you should know, because you will not get an ideal scenario. Sometimes you will not get a rise in the PCO2. Even if we had one patient yesterday, the PCO2 did not rise. It rose by just 16. And by the law says it has to be rise by more than 20 or up to more than 60. What to do? What if the PCO2 is low? What to do? What if the PCO2 is very high to begin with? What to do? So many ifs and buts. The patient becomes falls in the. So what I do before the apnea test is I cheat. And what is cheating? I give a very small purge of no red to the patient before I do the apnea test. I raise the blood pressure. I expect the blood pressure is likely to fall. I want to conduct my apnea test correctly. So if the patient is having a borderline blood pressure 110, 120, I give a small bolus 0.5 ml to 1 cc of NORAD to the patient so that my apnea test is conducted smoothly. There is no drop in the blood pressure. There is no fall in the saturation. All those things are taken care of. So you have to be smart enough before you do this test. Because if you give up this doing the apnea test, then the patient will never ever make it for the certification. And you don't need a consent for the apnea test. Please remember that. You know, people always say, do you need a consent? I also had this query. It's a clinical test which you're doing in a person. You do it. I mean, you can always inform to the family that we want to do the apnea test to certify if you want, but the consent is not needed by the law. This is the paper I was talking about, 2011, where the guidelines have come up, and these are the few differences. Most important thing is the waiting period between the two tests, which lasts from 12 hours to 24 hours, depending upon the age of the child. And the ancillary test, again, I'll be talking about a little bit. The only thing you must understand that this test should be done, especially in the very young children, in the presence of the people who are regularly dealing with the children. It could be pediatric neurologists, pediatric neurocritical care person, pediatric neurosurgeons, or those who are well versed in elicitation of various reflexes in the children. I'm a pediatric neurosurgeon, but still, when I get a child 1 to 2 years of age, I always follow up on a pediatric neurologist as a second examiner to make my point more clear and the test look more valid. Though I know how to do it, but still, I call the pediatric neurologist in all my children certification process. So just to be very safe, because there is no margin of error in such cases. You have to be very clear in what you certify, very clear in your demonstration of the clinical tests in such cases. So determination of the brainstem death is a little bit tricky in children. You need to be careful. Then consent from one and or the both parents. The law says you need consent from one parent, if you read the law correctly. But some administrators in some institutes, including mine, they say that you need consent for both the parents. Where do you get the second parent? The second parent is in another city, sitting 500 kilometers away. So the entire process gets repeated. I think we should be very clear in laying down the law. If it is for two parents, fine, we respect it. But then it has to be very clear what is to be done and what is not to be done. In Western countries, more so, when you have this battered baby syndrome, there's so many medical legal issues, and there you need special permissions, though it is not so commonly seen in our country. And so then I think the law speaks different and the practice is very different. We have to understand this. Children have got small pupils, small palpebral fissure, small external auditory canal. Everything is so small, tiny, teeny weeny. So for doing the test, you need to have those expertise. How much of the ice cold saline you have to inject. Those are the small things which is not mentioned in the law, but you have to read the subject and then lay down your SOPs. We have laid down our standard operative procedures for our center, and we will be very happy to share with you. Paneet has it. I can also share it with you. And so this is what I was talking about, ventilator autocycling. This respiratory mismatch is very common. All you have to do is to shift the trigger sensitivity of the ventilator from the flow trigger to the pressure trigger. If you do it, it's always taken care of. And this issue can be addressed very easily because it leads to delay in the apnea test most of the setups. And this is about the Lazarus 10. I was talking about my nurse and even my Syrian anesthetic. They said, oh my God, what the hell are you doing? But this was actually brain dead, and this child actually donated the organ subsequently, and we substantiated it. So you should know your ventilator well. This is what I would say, when you are doing these things. And these are the warning signs. Any person with a normal CT scan, the blood pressure is normal, no inotropes, it's a warning sign. This person is unlikely to be brain dead. Very clear. And there are a few red herrings, which I will skip it in the interest of time. And so these are the children which we can, so very young children can donate. Even the children with the brain tumors can donate. And of course, the fear in the minds of the family and the clinician, they need to be addressed. And it's always better to have a pediatric neurologist on board with you. So compound hand injury. Is it a contraindication? I struggled for almost 4 days when I was traveling to convince my junior faculty. He was talking about issues like meningoencephalitis and other crappy things. So I had to intervene to convince that, yes, this is a child who can donate, and the child actually donated. So I'm telling you, people who are well-read are the most difficult and the formidable people to address to. So it is where you have to be very firm and very clear. You have to know the subject, read your subject. This is what I'm telling repeatedly. You should be very clear in the statements you are making and what you are talking. If you are clear, be fearless and do consult people. I consult NOTP, Dr. Anil Kumar, so many times whenever I've got any doubts. I consult Ishwar so many times whenever I've got any doubts. So it's just not because I'm a full professor, I know everything, or just because I'm sitting in institute, I know everything. There's always a learning process. You talk to your peer group and resolve all the small nitty-gritties. So the test is not possible. Apnea test may not be possible at times. You may not be able to put in an arterial line in a one-year-old child. You have to think of alternatives. You could do a CT angiogram because the central venous catheter is already in place. So those are the cases which you need to know. The test is prematurely about it, inconclusive, how to resolve those things. That change should be known. And so these are the ancillary tests. The CT angiogram is one test which can be done. Bedside also it can be done. It is difficult to shift a child for the DSA. EEG is very, very inconclusive in the children. It gives more of a false positive results. In the busy ICU setup with so much of noise of the machines all around, you're unlikely to get a perfect EEG silence in ICU. So I always believe that EEG is not the good test. In such cases, TCD, many of the ICUs, they don't have it. Angiogram, you cannot shift a patient down. So the best test which we have come up with is a CT angiogram. And it takes just less than 1 minute to do the test, and it's very doable, and it documents the absence of cerebral blood flow to the perfection. And we have started doing it in our trauma center, many cases which we have done in the recent 6 months or so. And so this is what this is how it looks like. So I think I as a doctor, I as a neurosurgeon, I as a clinician, I'm pretty convinced that it takes many people to make a donation happen, and everything has to fall in place for a successful retrieval and transplantation. Change in thought process has to take place from a thankless job to passion, and this is something which we need to have in us. In case we want to be a part of this program, this is something which we need to have, because at the end of the day, if not we, then who will do it? Don't expect the policy makers sitting in the NOTP or the NOTTO or the SOTO or the ROTO to come to the ICU to do this. They are there to lay down the guidelines and the law and to help you out. But at the end of the day, the people sitting at the back, you are the one who will be able to do it. So you need to take the initiative. You need to come out and say, yes, what I'm doing is correct. Like I do 6 operations in a week. As of today, I got ORs 3 days in a week, 6 cases. So probably I save 6 lives. But when I do one organ donation attempt, once in a week or twice in a week, I immediately save 6 to 8 or maybe 9 lives. So that is equivalent to my working for almost 5 days in a week. I have to put in just 4 hours of my extra clinical time in coordinating these things with my colleagues and setting up the program. So you can understand you are actually indirectly, at the end of the day, we are doctors to save lives, right? Either you save life from somebody who's living, or you save life and give life to somebody who's from the brain dead. So if this concept is clear to you, I think most of the problems in our country will be taken care of. And Margaret Mead, I don't know how many of you know, she was a kind of a philanthropist from USA. And she always used to say, never underestimate the power of a small group of committed people to change the world. So the people who are sitting here, I presume many of you, I don't think any of you is a kind of a, just to add to the crowd of the audience. I believe that all of you are genuinely interested in this concept. And it is this small group of people who are sitting in this hall who can actually, help in changing the entire program. This is Professor Nakagawa, who is a key person in the pediatric guidelines all over the world. And you always say that one donor family changed the world for many people, but it is our small committed community that allowed that change to happen. So we need serious commitment, and this is what Dr. Abdul Kalam always used to say, one day we all will depart, but we need to see how we are actually living. So to conclude, my last slide, brain death criteria holds good in the pediatric age group, the same as the adult, with some minor tweaking around. And one needs to be very cautious in applying brain death criteria in the young infants. That is something which we need to be very, very careful. And we do regular simulation workshop. We'll be doing the workshop in the afternoon for those who are interested on the 3G simulators, and anybody is most welcome to join us. And we have laid down the SOPs. It's a 12-page something SOPs. And it's a very detailed SOP, the troubleshooting, the various problems which we had in our program in last few months. So I would say we have detailed each of them. We'll be very happy to share it with you. And that's our team of organ procurement team at Trauma Center, which is working day in and day out. In fact, even now we have got 2 potential donors in the ICU. Let's see what happens to them. And this is the book we have come up with on brain death, organ donation, and transplantation, which is available on Amazon as of now. And I'll be very happy to take up any questions. Thank you so much. Later. I mean, if you want now, we can do it now. We can do it later. That will be better. As you say. अगर वो लोग थक गए उससे तो बाद में कर देंगे हम लोग. The audience needs to be okay. Any questions? Please.
My question is this 12 hours time. See, time is very precious. When you plan for organ donation and you have to coordinate. So when you start actually process of after second test of confirming, or is it possible you can do it by different people that brain death certification, or time can be reduced? So how we can expedite the process?
Yeah, it's a very good question. Actually, Paneet will agree with me because I used to really force my people to do the test early and save time. Because once a patient becomes unstable, then the organs will go waste. So again, if as a clinician, if you know a wonderful drug available with you in your ICU, it's called methylprednisolone or hydrocortisone. Our patients used to die within 12 hours of brain death. 12 hours, 6 hours, they would become unstable, get an arrest. And we were wondering what to do. And if you read the subject, it's all mentioned. People have been doing it for many months and years and centuries in different hospitals. So we started giving methylprednisolone as a policy to all our patients. And trust me, most of our patients we are able to pull even for a day, 2 and 3 also. Very easily. The brainstem which is there, it is taken care of, number one. The children usually sustain slightly longer, maybe 3 or 4 days. So to address your question, what we do is, we are super aggressive in doing the first apnea test. By super aggressive, I mean the temperature. People always talk about 37. We don't go for 37. We go for 35. We don't want to go for a serum sodium of 135. The moment my serum sodium is crossed 115, most of these patients actually have got hypernatremia. The sodium is 160, 170. So the moment my sodium comes down from 165 to 160, I don't wait even for a second. So the small things which, the moment person touches a target, biochemical target, yes, I can do it. The first thing I do is I'll do my apnea test, first apnea test. Then the next 6 hours, 12 hours, it's very easy to sustain them. That time we utilize to maintain the organs. So all our efforts, they shift from, taking care of somebody who's living to take care of somebody who's dead. So it is then we do all the workup, we call upon all the clinical team to come to the ICU, evaluation of the organs, COVID tests and other crappy things. We do every damn thing in those 6 to 12 hours so that we don't waste any time. And we do start talking to the family indirectly. We don't declare about the brain death, we don't talk officially, but we try to start understanding the family. The central lines and other things, they're all put in place. So that 12 hours is actually not a very long time, I would say. And it's only in the young children more than a year of age when you have to wait for 12 hours. But otherwise in the adults, we go for 6 hours. But it's not much of a wastage of time, but you should utilize each and every minute of your time, for sure. Yeah. Please.
If it's possible to maybe have the questions.
More discussion, because this is the life. Ishwar can be given the mic. Yeah.
I have a question which is related to, I work in ICU, I'm director of the ICU in Sapal. My name is Kapil. Sometimes I deal with patients who have underlying neurological conditions and they have brain death, but simultaneously they might also have sepsis. So can we take organs from these patients?
Very good question. So this also we have addressed now. I mean, people used to wait for almost 48 hours for the culture report to come. So we have come up with BioFire. We do BioFire assay wherein within 2 hours you can get the bacterial overgrowth. So any patient who is having a culture positive, not a MDR, if he's having a culture positive and has received 48 hours of culture sensitive antibiotics, that patient can be considered for organ donation. So what we do, we have also noted that almost all these patients will have a high PCT values. I mean, all the intensivists and the critical care people, we give so much of importance to a procalcitonin level. PCT high 4. I mean, come on, if you look at the trauma scenario, we have seen patients with a PCT of 98, no infection. What is more important is you should document a trend of fall. You know, we do PCT at the time of admission, day 1 and day 2, by the time we come for the organ donation. If you are able to document a fall in the PCT value, irrespective of whatever the value is like, the TLC trend is falling. There is no growth on the biofire assay. On the biofire, you get the culture positivity within 2 hours, 4 hours, easily. And then you can be considered for organ donation. It's a multi-drug resistant strains, especially in the presence of ARDS. You need to be careful and discouraged. Last question. Yeah.
Ask a couple of questions since I look after the pediatric ICU over here. We have seen quite a kids who are getting brain dead after CNS infections. Like you said, trauma is one of the leading cause, but what I perceive is that in our scenario, fulminant CNS infections may be a meningitis or an encephalitis leading to brain dead with raised intracranial pressure, and finally coning and the child getting brain dead. But what we have seen is that they develop quite a bit of hyperglycemia and hypernatremia, as you have already told. But their BP crashes suddenly, sir. And in that case, we have to load them with multiple inotropes. So my question is like, for how long do we need this BP to stabilize and to have that period of organ donation with us so as to retrieve those organs? Because what I have seen is that it takes a couple of days for their BP to exactly normalize.
So, see, first of all, unfortunately, if you look at the data from our country, we hardly have got any donations coming from the PICU. We hardly have any donations coming from the neurologist. We hardly have any donations coming from other parts. The only donations which are happening in our country is the trauma. So I'm presently talking about the trauma. In your scenario, wherein you got very young babies with multiple infections, again, if you have a MDR bug, naturally that child is out. If the bug is not MDR and you're able to maintain or titrate the blood pressure, even for 12 hours, 24 hours, for the blood pressure to come up, you try this hydrocortisone or methylprednisolone as a drug. You've got nothing to lose in such cases. Let me tell you that. Okay, you've got nothing to lose. All you're doing is to keep the organs healthy in those cases. And if the things fall back in place, then let the transplant or the retrieval team decide the suitability of what organs they can take. And in fact, we follow up our patients longitudinally. You know, once the patient gets a transplant, so what we do is at least for a week. I don't have access to what is happening to the patients after they receive transplant, but with the help of the clinicians who we know personally, I follow them for 7 days. So we have seen that the patients wherein the biofire culture, the biofire was negative, none of the patients developed a transplant infection. Okay, so it's all good. We have revised our antibiotic policy. That again is very important. The moment the patient enters into the criteria for brain death certification, we give them high generation antibiotics, which may look very foolish and silly, but this is how you have to act. I put them on carbapenem, yeah, because I just have got 24 to 48 hours with that person. And I go for everything what I can to give the best shot of the antibiotics, steroids and everything to keep the organs in the best condition. And it's all correct and well documented in the literature. I'm not doing something which is a kind of, something crazy. Yeah. All right. Thank you so much.
Thank you so much. Thank you, sir, for the insightful address. I would like to request Dr. Krishna Kumar, Director NOTTO, and Dr. Amrit Bhatia, AMS LHMC, to kindly felicitate the guests.
आगे थोड़ा सा फेस्टिवल से थोड़ा सा और आगे
Ma'am.
Young boy opened up on it. Looks at young faces, they remain silent. Come. He's the man who is doing all the work. Actually,
इधर सर
Light is not yeah, thank you.
With that, we have Dr. Rahul Pandit with us. Sir is going to take an address on protocols of donor management and case discussion. Sir is currently the Director of Intensive Care at Fortis Hospital in Mumbai, and Sir has done his MD in anesthesia from Grant Medical College and JG Hospital and has multiple fellowships. We welcome you, sir.
Thank you. Thank you very much for the kind invitation from NOTTO. It's indeed a pleasure and honor to be here today. Over the next 10 or 15 minutes, I'm going to talk about donor maintenance. And then perhaps if we have time, I've got around 7 or 8 case capsules of real cases, which during the part of either declaration of brainstem death or maintenance, we had some problems and how we actually tackled them. So I was really happy that the discussions during the day, which have been in the last 3 or 4 talks, have actually spoken what my heart always says. I was really pleased with Gupta sir, who said that he spent only 3 or 4 hours of his clinical time and actually saved 9 lives. I really invite you, Gupta sir, to come and talk to our public hospitals in Maharashtra as well, because we really want this kind of attitude to come from them, and it would be really nice to have you there. Now, the first and foremost, when do we actually start maintaining a donor? So the first thing is that you need to identify who is a potential donor. And the potential donor does not mean that you actually label them as donor. You label and you identify some patients who, despite maximal therapy, may sometimes progress on to brainstem death. So the first idea, as we all know, is to actually save their lives if we can. But in doing this, if you're not able to save their lives, then we basically talk about brainstem donation. And the acronym which I talk about is GIVE. So somebody who has a GCS of less than 5, and I'm an adult intensivist, I'm only talking for adults, I'm not talking about pediatrics at all, who is obviously intubated, who is requiring full ventilatory support, means he does not seem to have a good spontaneous ventilation, or there is no trigger on the ventilator, and the eye signs are either absent or abnormal. These patients are not brain dead yet, but they are the ones who may likely progress on to become brainstem dead. And if you start maintaining this patient right now, with physiology as close to normal as we can, then your problem will not be there when you actually want the patient to be ready for brainstem dead declaration, or you want the patient to go ahead and be actually managed as a donor. I think the general approach for this is you need to have a good housekeeping. What you need to do is you need to not categorize these patients differently as that they are actually organ donors. You need to categorize them that this is just a normal patient, and I'm going to continue to look after this patient as I would do for any other patient in my ICU. Use your standard approach, maintain extracranial organ perfusion, and I have got a slide to talk about that. Prevent the adverse sequelae of brainstem death, which have been quite nicely alluded by the previous speakers. Correct abnormal physiology. Exclude contraindications to donation, which probably have been already done, but if not, then keep an eye on that, and then consult organ donor agency like NOTTO, SOTO, ZTCC anytime what you want. Now, what happens is when you have a patient who is potential brain dead or who is now become brain dead and you want to do a brainstem death testing, the physiological support given to that patient at that particular time before you've actually identified them as an organ donor is to maintain the intracranial perfusion, because that's where you are trying to save the life. So everything, the mean arterial pressure, the cerebral perfusion pressure,
Everything is targeted at that. Your investigations and your clinical assessments are all organized around the central nervous system. And that is where you need to basically understand that you may have to now withdraw some of the brain oriented therapies. For example, once you have done the first test and the first test is positive, please stop that mannitol or 3% saline. It has got no use. And if you keep on adding that mannitol or 3% saline, you're going to cause a hyperosmolar case, more and more hypernatremia, hypovolemia, and hemodynamic instability and the patient crashing. So these are some of the things which we need to understand. Change the physiology to preserve the function of organs. Now, there are various maintenance criteria available. From our Indian Society of Critical Care Medicine, we have got an organ donor management guideline, which is our official position statement. Obviously, you need to think a lot about ventilation, fluid, inotropes, vasopressors, warming. Usual basic therapies need to be done, like cleaning, suctioning, turning. Physiotherapy needs to continue. Infection control is very important. Monitoring and investigations need to do. This is the paper. I've shared it with Archana madam. You can download it free from the Indian Journal of Critical Care Medicine as well. And it gives a very comprehensive understanding of how to actually manage a potential organ donor. Now, I have got some rules which we have made. And some of the rules are very simple. We talked about temperature. Many doctors talked about temperature today. It's very important to measure core temperature. The problem occurs when you don't measure core temperature and you only measure axillary temperature. These patients do not have a warming mechanism present. Their shivering mechanism is also absent. So they are not able to control their temperature. You put a thermometer in the axilla, trust me, it will show you 35, 37, 39. It will be all over the place. So try and maintain a core temperature, and I agree core temperature of 35 and above degrees centigrade should be enough. Or if you are measuring it in Celsius, 96 and above should be enough. You really don't need 97.8 or 98.6. Okay. Stop mannitol, phenytoin sodium, all those things which you have done after the first test is suggest you have brainstem death. Then there is something called the rule of 100. I like to measure this rule of 100. If you do the rule of 100, many a times your adult donor will be absolutely safe. Try to keep a systolic blood pressure of 100. Try to keep urine output of 100 ml per hour. Try to keep a temperature closer to 100 degrees Fahrenheit. Doesn't mean that you need to have a fever, but what I mean is 98 degrees Fahrenheit, if you can maintain, that will be really great. Every 100 minutes, assess volume and assess electrolytes. This is one of the grave mistakes we do. Assess the temperature every 100 minutes. Saturation, try and keep it as near as 100 as possible. So if you just remember this 100 as a number, rule of 100 actually makes it very, very easy for us to manage these patients. The vasopressors now have changed. We do not use noradrenaline as the first vasopressor anytime. If we have a patient who is organ donor or potential organ donor who is already becoming polyuric, a small replacement dose of vasopressin will be a very good vasopressor to begin with. Having said that, 85% of patients will require noradrenaline as well. Don't get me wrong, but vasopressor should be the first choice of vasopressor. Vasopressin should be the first choice of vasopressor in these patients. Let's go to some specific issues. Okay, respiratory care. The respiratory care should just continue. And I'm talking about patient has been declared as brainstem death, and we are waiting for organ retrieval to happen. Or during the first 6 hours between the two tests is what I'm talking about. Okay, so your routine suctioning, positioning, turning, your ventilatory techniques of using PEEP optimally, your recruitment maneuvers, if they de-recruit while the apnea test was done and the ventilator was disconnected for some time and you have a de-recruitment of the patient, make sure that you recruit the lungs again. You try and avoid a fluid overload and make sure that adequate oxygenation is done. As such, it's not difficult. It is our core day-to-day intensive care job, and this should be easily possible for all of us. Now, circulation, we talked about Cushing's reflex. It's usually a very transient thing. If you are very good in observing physiology, which all of us should be, intensively should be standing at the end of the bed, understanding what the physiological changes are happening. You can have a short use of esmolol or something, but in my practice, and this has been we've been doing for last so many years now, almost 6 to 8 donors we have in a year from a private hospital in Mumbai. for last 12 years, that would itself make around 100 donations, and plus another 10 years before that, we have not lost a single donor. We have not lost a single donor because my instructions were very clear to our juniors. And when I was learning that you've got to stand at the end of the bed and make sure that you observe the physiology. Use esmolol. Once in a while we have used it, really otherwise no need. Control arrhythmias, check for volume, check for electrolytes, maintain the temperature. And sometimes if you have a bradycardia which is resistant, atropine, adrenaline, isoprenaline may be used effectively. Now, the last statement can be a bit controversial, but I think in the time when we are talking about DCD, and we have Dr. Avnish is sitting here, Dr. Mathur sir is sitting here, we published a paper on how to actually do the DCD program in India. If you have a cardiac arrest in a patient who has had the 2 tests done and is just awaiting organ retrieval, by all means give a CPR. By all means try and do everything you can to try and salvage the organs as much as we can. If not, go for a DCD. Because usually the consent will be done by that time, and it is really not going to matter to the family whether you're going to do a BSD or a DCD donation. So remember that CPR may not be out of question in these patients at all. Sorry. Hypovolemia, I think this is often underestimated. Many patients become polyuric. They lose a large volume of your water, and you are almost certain to see that in form of hypernatremia and hypotension. So make sure that you adequately optimize the patient's volume. Now, what technique you use, this lecture is not intended for that. Whether you use CVP, whether you use a IVC diameter, or you use a stroke volume variation in the ICU to optimize the volume, I leave it to you. Use a technique which you are familiar with and make sure that the patient is adequately volume filled. Now, there can be sometimes competing requirements for organs. For example, if you've identified a patient where all organs are going to be donated and likely to be transplanted as well, you are in a problem. But if you've clearly identified that the patient's kidneys are not going to be donated because the creatinine is 5, I'm just giving an example, and the nephrologists have refused, then try and keep the patient a little bit on the drier side, because the lungs might be something which the lung surgeons would like to be dry. Because there are competing organ requirements. The nephrologists want them to be full, the cardiac surgeons and the lung transplant surgeons want them to be on the drier side. So you need to use your judicious approach as to how you are actually going to do this. Identify the donor early and make sure that you have a plan for the transplantation that way. Now, hypotension and low cardiac output. We need to understand, I talked about vasopressin be the first inotrope of choice, but more than 90 to 95% of our patients will require a vasopressor or inotropic support. Vasopressin is the first choice in our practice, and this is what we have mentioned in our ICCN guidelines as well. This is what the literature talks about as well. But around 85 to 90% of the patients will require, despite vasopressin, will require noradrenaline as the first choice. Do not use dopamine. If somebody is using dopamine, please get rid of the practice. Dopamine is arrhythmogenic. It is a drug which has been extensively studied and has been actually talked about for last 4 or 5 decades. And we have stopped using dopamine in all practices for last 1 decade or so. Yes, some cardiac surgeons still like to use it, but not in this category here. There's something called as hormonal resuscitation, which was touched upon by Dr. Gupta sir. Now, methylprednisolone in the dose of 15 milligram per kilogram can be given as a single dose, which equates to around 1 gram for an adult, if the lungs are going to be transplanted. If the lungs are not going to be retrieved, you can go for a replacement dose of hydrocortisone, 50 milligrams QID, which will be around 200 milligrams to 300 milligrams of hydrocortisone divided in 3 doses or 4 doses over the 24-hour period. So I think that is more than enough. What we usually don't follow very religiously is thyroxine. Now, unfortunately, we don't have IVT3 or IVT4. So if your ejection fraction is less than 45% and you have persistent hemodynamic instability, you need to think of some thyroid hormone replacement. Now, because IVT3 or IVT4 is not available with us, what we do is we give thyroxine 300 micrograms to the nasogastric tube. Now, this practice can be a bit challenging because we know that many of our brain dead patients have got poor gastric absorption, they've got large gastric gastroparesis, their gastric emptying also gets delayed, and that results in probably inadequate absorption of thyroid hormone. But what can we do? I think we don't have any other option other than giving a large dose of thyroxine through the nasogastric tube and wait for it to act. Diabetes insipidus, either a desmopressin spray or if you are using vasopressin as your first choice, which is what I've been trying to again and again repeat, then you don't need to use desmopressin spray. Just use vasopressin. Your diabetic insipidus will be taken care of. Usually, I start with 1 unit per hour of vasopressin as an infusion, which has got a good vasopressor effect as well as a good effect on the diabetic insipidus as well. Metabolic management. Most important is to measure the electrolytes again and again. So in a patient who is organ donor in our unit, we always put an arterial line, and my standing instructions are do ABG every 2 to 3 hourly. 100-minute rule. Again, rule of 100 is basically implemented. We look at the sodium and potassium from the ABG, we look at the glucose from the ABG, and we correct it as required. More often than not, it is hypernatremia which we have to correct and bring down the sodium rather than hyponatremia. Electrolytes, potassium are often required to be replaced along with magnesium. And the last but not the least is the hypothermia. Now, hypothermia is best prevented than corrected. If you have a patient who is hypothermic, say 31, 32 degrees centigrade, trust me, you will sweat out to actually bring the temperature up to 35, 36 degrees centigrade, because it takes a large amount of effort to bring the temperature up. But it takes only small amount of effort from temperature to be dropping down. So if you keep the patient warm, as soon as you've identified the give acronym, give them a warming blanket. Make sure you're giving them IV saline, which is warmed up, so that they don't lose their temperature. The ambient temperature is so cold in the ICU that the patient who has got no capacity to try and maintain the body temperature will cool down to the ambient temperature of the room very quickly. And I would not be wrong to say that 90% of those donors who are hemodynamically unstable, hypothermia plays a big role in them. So please, if your donor is unstable, insert an esophageal or rectal thermometer and look at the temperature. Trust me, it will be hypothermia on more occasions than not. Anemia and coagulopathy, nothing really great. Your patient is going in for a surgery, though it's a retrieval of an organ. Make sure that you correct the blood and hemoglobin coagulation problems. Nutrition, continue your enteral feeding. It will be beneficial for organ support and transplant recipients. However, be wary of the gastrostasis. Neuromuscular blocking agents. Now you might argue, why have I put this here? Now, just like all the persons who are basically diagnosing brainstem death, we all have been burnt by Lazarus reflex. So I remember a girl, we had 2 donations, 2 tests done. I was handed over the unit on Monday morning saying that we are just waiting for the transplant team to come in half an hour, and the patient will be taken up to the theater. And this 6-year-old girl sees her mom's hand move and says, she's not dead. That's right. 6-year-old girl sees her mom's hand move. She's not dead. That, as far as the girl is concerned, she's right. I had to go through the whole entire process of doing another set of tests. Explaining to that 6-year-old girl was very difficult. That girl followed up. The donation went through ultimately. The girl followed up with me. The 6-year-old girl followed up with me for 6 months on multiple occasions after that. This is in Sydney I am talking about. And I had to go through a lot of effort with child counselor to try and get this girl into the understanding mode that this was indeed a brainstem death. Imagine adults not understanding what a 6-year-old girl would have understood. And I still, to this day, I still fear what happened to that girl. Was she left with post-traumatic stress and depression or disorders? So if your patient is going in for the theater, about to be wheeled in, they are going to receive a neuromuscular blocking agent anyways in the theater. Just before that, give a dose of neuromuscular blocking agent. What happens is, as soon as the patient comes out, a lot of relatives go and touch them, hug them. At that time, if they move the hand, then you are in a problem. So that is the time when you can use a neuromuscular blocking agent just before they are being wheeled to the theater. Okay. Last couple of slides. So donor management during organ retrieval, anesthetists should continue what we are doing in the ICU. Normal ventilatory and circulatory parameters, neuromuscular blocking agents, so that surgeons don't feel the jerk of suddenly the hand moving when they are taking a bold incision on the sternum to the pelvis. All these things need to be taken care of. Severe oxygenation failure. I have even prone a potential brain dead patient after first test to see whether we could actually get across and have a better oxygenation or not. Spinal reflexes are common, and we need to understand and talk to the family. Ever since that episode around 15 years ago, I have now gone across and talked about spinal reflexes to every patient and for every patient's family. And in the last almost 17, 18 years that I've been doing this, I have the family member present with me when I'm doing the test inside the room, and I'm very confident. And I've had a couple of occasions where spinal reflexes have happened, and because I've spoken with that about it to the family, they've accepted it as well. So they need to really understand it. Sometimes you need to go back and do another testing, which is fine. But when they see the apnea test, when they see the neurological reflexes are absent, the penny drops. The understanding and the agreement for a death happens at that time. But I must say one thing, word of caution: if you are not confident of what you are doing, and if you're going to take help from other people while you are doing it, don't get the relative inside. So if you're fully aware and fully confident of what you're doing, you've done hundreds of tests before, please go ahead and get the family inside. It will make a difference in their understanding of the acceptance of the death. That is the most important thing which will happen with that. That's it. Basically, you just do a simple day-to-day ICU approach. You don't really need to be innovative at all. Just consider these patients as a normal patient in your ICU. Continue treating them, and trust me, you will do a good job. Thank you very much. No, I don't want to play. I've got 6 or 7 case capsules. If I have time, I can show them. Otherwise, we can do it later. We can do it later. That's okay. Just open up. So these are just, I want audience interaction in this. These are all real life patients. I might just skip up to this and say the Lazarus reflex we've talked about. I've already talked about this. Okay. Day 2, female, 22 years, alleged history of unknown poisoning, brainstem death test done 48 hours post-admission. Both tests happened, apnea test certified, but there is no documentation of hypoxia, arrest, trauma. Cause of brainstem death is called as metabolic encephalopathy. How many of you would go ahead and agree to this brainstem death testing? Just show of hands. How many of you don't agree to it? I'm thankful. Very good. Now, none of these cases are made up by me. These are all cases which I have been referred to and have been talked about. So in poisoning, be very, very worried. Intensive care, very common to see organophosphate poisoning. Remember, day 9, day 10, they have something called the intermediate syndrome where they might actually mimic to become again brainstem mimic is what we talked about. So be very, very worried. There is no clear sign of why this patient should be brain dead. Take 5 steps back, reassess the whole process. 99.99% the patient is not brain dead. So you need to be very, very clear about it. One more. Patient has got 43-year-old traumatic brain injury, aspiration pneumonia. On FiO2 of 1 or 100, the PO2 is 264. Attempt to an apnea test is done, but he desaturates. How can he complete the apnea test? Any ideas? Of course, you can go to an ancillary test, but any out-of-the-box thinking how you can do an apnea test? Any intensivists or anesthetists from the crowd? HFNC. So HFNC may not be useful because you've got an endotracheal tube. You're not going to extubate the patient. You will not be able to give high flow oxygen through that. ECMO, but you would not put a patient on ECMO for just completing a test. If the patient is already on ECMO, it's a different thing. But 99.9% of the patients are not going to be on ECMO. So what? Yeah, but you're not going to put a patient on ECMO just to do a test, right? You can do a simple Bain circuit, madam. So Bain circuit, all of you are aware, has got a little valve. You can open the valve half. That sort of gives you a small amount of feed. And majority of the tests in which I have struggled because of hypoxia, we have been able to complete the test using this. And the beauty of the Bain circuit is that you can actually see the bag moving if the patient attempts to breathe. So it's a very, very nice way of doing it rather than disconnecting it. Just one more point about putting the catheter and 5 to 6 liters of oxygen through that. We have published one paper now where there was a series of pneumothoraces in 2-3 hospitals in Maharashtra while they were doing the apnea test. Try and make sure that the catheter which you insert to instill oxygen 2 to 4 liters or 6 liters per minute, first limit the rate to below 6. That's the number one rule. 2, make sure that the diameter of the catheter is at least 1/3 the size of the endotracheal tube, not more than that. If it is covering more than 50% of your tube lumen and you give 6 liters of gas, you will actually cause a one-way valve effect. And with that, sometimes bilateral pneumothoracic can happen. So we published a paper on that as well. So just make sure you can do this. So this is a picture of a brain circuit. Quickly, patient reported to roto as brainstem death for distribution of organs. Can you see the scan? What is the, can you see the ABG, sorry? What is the problem here? So you can see the PCO2 before is 26 and the PCO2 afterwards is 51 there. Technically, there is a rise of more than 20. Okay. Now, trust me, when we are doing the brainstem death, we are actually being given authority by the law to do it in the right way. So the rule of 20 does exist, but that exists when you start off with a baseline of 35 to 45, not when you start with a baseline of 26. In this case, it should have gone above 60. The second, I use that rule of 20 in patients who are CO2 retainers. So if patients who are CO2 retainers, if I am not able to get the PCO2 below say 50 or 55, then I use that rule of 20, where if I start from 55, I go to 75, and then I declare this patient brain dead. Rule of 20 is used very commonly by many of the intensivists and neurologists across, saying कि 20 से बढ़ गया. That's not right. You should have every attempt to make the PCO2 between 35 and 45 at the baseline, and then go up to 60. But if you're not able to get it below 50 or for some reason, then of course you use the rule of 20. Just 1 or 2 slides, madam, and I'll be done. I'll do very quickly. Another ABG. What's the problem in this? You can see that the sodium is 181. Pre and post apnea test ABG is 181. Okay. So again, the law has given us an authority to do it in the best possible way as possible. I agree with Gupta sir. We don't wait for 150, but 180 is, I think, we're stretching it too much. You know, you are just not giving actual attention to what the physiology is. This patient must be hypovolemic, hypernatremic, and it would not serve any purpose. And there is good data to say that first and foremost, you should have got it before testing it. And 2, even if this patient would go for organ donation, there are organs which actually do very poorly when the liver is, especially the liver, when the sodium is very high. Last test and I'll be done. This is one question this is one case which I want to discuss for a minute, and I'll stop. Trust me. We had a patient who, this is again a real life story, 26-year-old male, high-ranking civil official, his son hanging at home. Patient was brought in, brain dead diagnosed. Father wanted us to go ahead and do both the apnea test. Please do it. We would like to donate and we would like to do things. Anyways, the family was very educated, so they knew everything. But as soon as I was a civil servant, everybody, we were all sort of trying to just communicate. Anyways, after around 4 days, the heart ultimately stopped. Now, because it was a medico-legal case, the postmortem question came in. And then the time of death came, because I had written in the notes, time of death 4 days ago. The policeman could not understand. Marathi में बोल रहा था, 4 दिन हो गया अभी आप बुला रहे हो, and then why have you kept this patient for 4 days here? The father was saying heart अभी बंद हुआ है. So these are some of the legal problems which you may face, and there is no recipe or no solution for this. Case by case you have to take. I took a step back. I wrote in the notes a very detailed explanation of what happened, and we put the time of death as the cardiac arrest. What can we do? Okay. So sometimes, despite the best of the intentions, you have to take a step back. So remember, not every scenario can be written up by the law, but we have to use sometimes common judgment, common sense, and just help ourselves out. Thank you very much.
Thank you so much, sir, for that beautiful address as well as those insightful case discussions. I would like to request Dr. Archana and from NOTTO and Dr. Praveen Mittal, EMS Agency, to please felicitate, sir. Thank you, sir. With that, we would like to call upon our next speaker, Dr. Dinesh Neki. Sir will be taking an address on legal framework of brainstem death with different forms and its procedure. Sir has done his MBBS from Maulana Azad Medical College and MHA from AIIMS New Delhi and is currently serving as the Chief Medical Officer Administrator. I would like to welcome sir.
Good afternoon, everybody. I'm standing between you and the lunch. My work has already been much easier by my earlier speakers. Most of them have been covered by Dr. Mathur, Dr. Gupta. There are certain things because when, from the legal point of view, when we see certain things, because if anything goes wrong anywhere, it is the documents which are checked at that time. So there, what was the need has already been elaborated. And now THOA has already been explained. These are the punishments because of which we are afraid to handle these things. And this is where point number 2, which makes it mandatory for a doctor in the ICU to ascertain if a family wants to donate organs. Because of which the whole workshop which is there for brain death, and as earlier said by Dr. Pandit, it should be decoupled with the transplant. First of all, we should understand we are the country, we have less resources are there. ICU resources are restricted only. So it should be taken different, and when brain death, and already the government is working on to modify the death. Because as per the law, in the 3, the Registration of Birth and Death Act defines section 46 of the Indian Penal Code defines it, and the transplant of human organ, and these are being now amalgamated to come up with one this thing. In the birth and death, it is means the permanent disappearance of all evidences of life at any time after live birth has taken place, and brain and death. Brain stem means the stage at which all the functions of the brain stem have permanently and irreversibly ceased. This has already been elaborated. And donation, authorized medical board has to certify the things. The board has already been discussed in elaboration. Everything has been there. There are 21 forms which are there. Now, out of which I will concentrate on these. Form 7 is in which we ask about the pledge to take the for donation. And this is Form 8, consent is there. When a person is suspected or for a BSD, then the Form 8 in positive or in negative should always be get it filled up. That is mandatory. They allow you or they don't allow you. If they allow it, then you go ahead with it. If you don't allow it, just keep it in the records. And when we side as a witness, because these are the things where we fall. When we say witness, we just get a name or anything then. Like in the witnesses, whenever see, it should be completely who the person is. Whether you should be able to identify that person. Because from legal point of view, if you cannot identify the person, then it becomes a later on a problem. कि किसने दिया था, कौन दिया था, किसको identify नहीं कर सकते. These are the, because witness means if anything goes out of order or if it is there a dispute, then these are the witnesses which you can identify. And as far as if you can, these are the things which are written. And if Aadhaar card, if you can, people are ready to give, write the Aadhaar card, because these are the unique IDs. Always try to take a unique ID so that they can be identified. So for certification, this is the, when the board has to certify, it has to certify in this form, and it has to be the board completely responsible. It is not one man person. And these are the things which our neurologists and this thing have been filling day in and day out. And now the NOTTO program, our Honorable Prime Minister himself said, I think this is very important because everything we are working for the life. And procedure in how it to be in the medical legal, this is what has been mentioned it, and we, as already discussed earlier, we should be saying that the post-mortem and other things should happen on the table itself only. Because I was talking certain forensic people, because they want to, if they want to open the cranium, other things, that saw can also come, because now it is with the vacuum material, it can be done easily, because it is only the cooperation and mindset and attitude which needs to be changed. So if we are doing everything, anything done in good faith is not a crime, and that is already given in section 23. No suit or prosecution or any other legal proceeding shall be lie against any person for anything which is in good faith, done or intended to be done in pursuance of the provision of this act. So no suit for the government can also be filed. That is the take-home message is anything done in good faith is not a crime. Only thing, my whole purpose of this presentation was is we should document it properly in the letter and words which has been described. We should not take it leniently. If the witness is to be written, the name on the documents which are there should be clearly mentioned so that there is no discrepancy at all. Thank you. That is what I have to just brief in. And there are few dictums which are very close to my heart. That is, your eyes cannot see what your mind does not know. So your mind should always be seeing the things. And anything not documented, not done. And the day you stop considering yourself as a student, you will always make a mistake.
Thank you so much, sir, for that beautiful address. I would like to now request Dr. Archana and Dr. Sheetal Joshi to kindly felicitate, sir. With this, we would like to begin our panel discussion for the day. Our first speaker for the panel is Dr. Anup Kumar. So, is a professor and chairman, Department of Urology, Robotics and Renal Transplant at Safdarjung and VMMC New Delhi. We welcome, sir. Our next speaker is Colonel Dr. Avneesh Seth, VSM. Sir is the head of gastroenterology and hepatology at Manifesto Hospital, Delhi. And Sir has served in the armed forces previously. He's also the founder director of Aorta in 2007 and the founder director of Fortis Organ Retrieval and Transplant. We welcome, sir. I would like to request the audience to please give a huge round of applause to our speakers. Our third speaker for the panel discussion is Dr. Archana Kumari. Ma'am is a consultant coordination at NOTTO, Ministry of Health and Family Welfare. Our next speaker is Professor Dr. Vijay Kumar, who is a cardiac, thoracic and vascular surgeon at RMN Hospital, Delhi. I would like to request the audience to kindly provide speakers with a huge round of applause. Our next speaker is Dr. Nishan Kumar. Sir is currently the professor at Department of Anesthesia in Lady Hardinge Medical College and works in the areas of critical care, etc. I would like to request the audience to kindly give a huge round of applause to the speaker. We also have with us ACP Vijay Malik, who joined the Delhi Police in 1990 and worked in different organizations of the Delhi Police, including the ones mentioned on the slide. I would like to request the audience to please give a huge round of applause to our speaker. Our moderator for the panel discussion to kindly come up on stage. So is currently the chairman, Department of Renal Transplant Surgery at Sir Gangaram Hospital, and has a multitude of accolades and achievements that we probably cannot complete in the time that we have right now. We welcome Sir and all our speakers here for the panel discussion.
May I start? ये चलने दो. Good afternoon, ladies and gentlemen.
Projector off, please. Projector off. Projector room. Projector off.
Good afternoon, ladies and gentlemen. I'll take the privilege of being the moderator, and therefore I'll moderate right from the beginning. There are two ladies here who are wonderful, who take full advantage of my good behavior with ladies, and they stick me into something like this, half an hour, right, with 6 speakers of eminence. How on earth can anybody do justice as a moderator? Yeah, but that means we have got 4 minutes per speaker, very strictly, so that we can cheat about 5 minutes at the end so we can have some questions. So I will even tamper with the list in which we are going to speak. All right. So the first person I'm going to ask to speak is on a positive note, and that is, we are going to ask Dr. Grover first to say, congratulations for doing the first heart transplant in RML Hospital. It is a fantastic achievement. And I would just like to know in very brief from you, what are the challenges and obstacles you have faced from the beginning to the implementation and to its execution? I know it's a very short brief, but we would like to know the punch which you have got.
Okay. We believed that we could do a transplant 7 years back. So you can understand it took us 7 years to come to the step of doing a transplant. So the first step was to we were prepared, the unit was prepared, it was identified that we could do it. Then the clearances from the permission as a transplant retrieval and transplant center. But there was a lot of hitches and in the cardiology side, identifying patients of heart failure who will be identified, and a lot of dilly-dallying from as could we do it in the sense of the administrative part, the type of nature of how will we organize because most of the patients that come in the heart failure therapy in a government hospital who are eligible for a transplant are very poor. So economics was a very big challenge to start off, to how to be able to identify them, work them up, and build them up. Second thing, when we were ready, just around a year back, when we said yes, we can do it, we went to various centers like AIMS mainly to see how this program functions, and we were able to say that it's nothing great, we can do it. Nothing great, it's all a matter of doing it. And when the crunch came, when we actually came to, we had a few calls. Then there was problem of retrieval. How do we really work out going to Chandigarh and coming back? Like this transplant patient was Chandigarh. Somehow our administration was very, very excited. Our NOTTO coordinator was very excited. And the excitement made us do all this thing in a jiffy. But I'm not sure whether this excitement is enough, because ultimately it's the protocol, it is the system which has to be made very, very strong so that we can do that efficiently every time. And logistically, we were short of space. We had to cancel a few patients. We got adverse publicity for that reason also. We had to postpone a few cases because the ICU was small. We had to isolate the patient and take care. But anyway, we succeeded because the patient was young. The right choice of patient, right choice of donor. The administration, the blood bank, the heart failure team, all stood up with us and did a commendable job. The second part, the challenge has now started of providing immunotherapy for the patient and looking after the patient.
especially on the poor strata of society. These patients do not have appropriate housing, appropriate living conditions, appropriate finances. So that is a big challenge that we are facing right now, but patient has been doing well. So I think it's a pat on the back for us for the first case, but I hope we can maintain it for the next few cases.
In a typical way, you have been very humble. Your role in the whole thing you have minimized. The fact of the thing is, a good leader provides good leadership and you get good results. So, for somebody in this hospital at RML to do a heart transplant is not a small achievement. So, I think all of us can put our hands together and give another one. Yeah?
Thank you so much.
Excellent. So, that brings me to the other study. Right? So, why is brainstem declaration not one of the routine procedures in the ICU? And what do you think we should do? Is there a lack of attitude, or is there a lack of knowledge, or is there a lack of commitment? What do you think we should do? We've got all the laws, we've got the transplant coordinators, and people know what to do, but we are not getting the kind of.
I'll talk about the general ICUs first, because if we talk about the trauma ICUs and the neuro ICUs, there the people and the clinicians are still sensitized about what is brainstem death. When we talk of the general ICU, as has been said since morning, it is the clinicians that we first need to educate, because for us, death means a cardiorespiratory arrest. Brainstem death in the general ICU is still not a known thing. We do get hypoxic patients, we do get patients with hypoxic encephalopathy, and we know that it's a point of no return, but still we wait for that cardiorespiratory arrest. So it is basically the ignorance that brainstem deaths exist. And again, as has been said by the previous speakers, we have to delink it from the organ donation, first of all. First, it has to come to us that, okay, brainstem death is a type of death. We have to stop and withdraw support at that point and declare death. So that is what we are not doing, unfortunately. So that is, I think, is the main stumbling block. And I think, as has been, yeah.
You think it will go a long way?
It will go a long way. It will go a long way because we are still afraid. I mean, unofficially, we do DNR, we do, okay, we do not increase vasopressors. We, okay, fine, it's time, let the patient go. We do all of these things. I mean, it is a hidden secret, it's an open secret that we all do these kinds of things. But yes, this will definitely, if it is in black and white, it will definitely go a long way. And at least that a small amount of fear which is there, that, okay, we might be doing something wrong, that is taken care of.
What about the mandatory declaration of brainstem death? Some states have already introduced it.
Exactly. So that is what, I mean, in Delhi, it's still a question mark. So if it becomes a universal black and white thing, okay, this is recognized by law, this is applicable throughout India. So definitely we'll be more willing to accept it.
Thank you. Now, can we come to Dr. Anu? Yeah. We started with the brainstem death. Where are we now in Sabdai? You are such a well-recognized and so enthusiastic transplant surgeon and urologist who is now internationally recognized on giving, robotic and other kinds of. Why is it that Sabdarjung is lacking behind, especially when NOTTO is right in the center of it? Sorry, this is what a moderator is all about.
No, sorry. So we started the cadaveric or diseased organ donation program way back in 2016. And of course, you are in NOTTO since inception of NOTTO, so you know everything. I'm the nodal officer of the kidney transplant. And when we started this program, that was the first in the central health services. Even Reversible was not doing the disease organ donation at that time. So we started with making our list. Our nephrologist, Dr. Rizvi, was there. He was very young and dynamic nephrologist. He helped us. We made a list of 10-15 patients. And we started the whole protocols. Everything was in place. And we started doing the diseased organ retrievals. We did around 15 in a span of 9 to 10 months. And that was a time when, yes, everything was going right. But the problem started when our nephrologist, he left the hospital. So that is on the record. And once he left the hospital because of various reasons, we had only one nephrologist. And he said, I can't run the cadaveric transplant program. Either you run the live transplant or you run the cadaveric transplant. So we had no choice but to stop, and this is on official record. We have to stop the cadaveric transplant because of the non-availability of a dedicated nephrologist. And this continued. Then the COVID came, and then, of course, we have now a new nephrologist, Dr. Himanshu. I'm putting it on record. He's a very, very dynamic and sincere nephrologist. Ever since he joined, he said, now we can do the cadaveric transplant. So we have now a team of 5 nephrologists. They are newly appointed by UPSC. And now we are doing 2 live transplants in a week. We have started doing the robotic transplants also. This is the first in the country in the government hospital. And of course, now the bottleneck is to get the patient from ICU, where we can actually start the process to get the consent. So everything is in process. We have very good transplant coordinators. We have the team ready for retrieval. We have OT set up, state of the art OTs. The problem is to get the patient notified from that particular department. And now for that, I had a couple of meetings with MS and all of our stakeholders. We are hoping we're going to start very soon. So now the bottleneck is gone, that nephrologist bottleneck, but the main bottleneck now is to get the patient from the ICU. And I think we are hearing the lectures. I hope, like Dr. Deepak is my senior from Lady Harding, someone like his caliber, it takes the charge in our hospital also, because I can't go there and identify the patient. I'm the nodal officer and I'm the transplant surgeon. I can do everything, but I can't pick up the patients. This something has to be done by the concerned ICUs. And I hope our whole team will again combine together like we did in 2016. And that was a big news at that time. And I think next 1 or 2 months, you'll see retrievals being done.
Can I ask you 2 separate questions? Yeah. One is that we have got in Safdarjung, we have got an operation theatre designed specially for cadaveric organ retrieval, and it can very well be used for training of retrieval teams. Yes. And at the moment, it is being used for very little apart from storing a few things. Now, it's not pointing at you. I know about it because I was there at NOTTO all the time. I put it to you that we require retrieval teams to be trained. We have got Sheetal sitting over here. She has come forward. We have got Dr. Sarangi in the other hospital over there. We have got people all over the place with 2 or 3 anatomy departments, dead bodies coming, which we can use for retrievals, training. And you can have a formal retrieval training at the OT in NOTTO. Because that is where the lacuna is. Also, apart from what you said, you cannot be everywhere. I can't be everywhere. People cannot be everywhere. But you have to now get the second one. That's one. I'll get your response. The second one is, this is conceptual. You got nephrologists in one hospital, the other hospital, wherever. If the need arises, can we not from NOTTO or from the ministry or from the directorate, like you got a panel of doctors coming, can we not make a panel of nephrologists who come along and assist you at that particular time?
So I will answer you both the questions, sir. Firstly, the training. So I've trained my whole team, sir. We have a team of not 12 urologists. Out of that, 6 can do the retrieval. So, but I totally agree that we need a retrieval center, training center. Now, for that, we need a refrigerator which can keep the dead bodies, cadavers for -20. And that machine, we are trying to, because that cannot be, I can't buy that. It will come under either forensic or anatomy department. Those departments are trying to buy it for last 6 years. Because of Make in India clause and because of GEM clause, they could not buy that machine, that refrigerator. So that is the only, again, the bottleneck. Otherwise, everything is in place. That is number 1. But I totally agree, we need more training centers. And I am, of course, already trained, my team is trained, and we are very happy to train others also. And number 2 is, you said, regarding the panel of nephrologists. So you must be remembering at that time I discussed with you, 2017 when this happened. I discussed with our DGHS, Dr. Jagdish Prasad was there. And he was saying, yes, it can be done. But problem is again, that as per the law, you can't have a part-time nephrologist taking care of a transplant program. That was the main hindrance in that problem. Now I can call somebody from RML hospital. I tried the RML reference to give cover to us. They refused. They said problems. And I tried with DGHS also. They were ready to help us. But you know, sir. I mean, in a government setup, can't go out of the rules. Even if you are in the right spirit, because something goes wrong, you will be always pointed out. So that's why nobody wants to take that risk. And that's why you have to wait till we get the full-time nephrologist in our hospital. Now it's the time. Now we are doing the incompatible, AV incompatible also. We are doing the robotic transplant also, and very soon we are going to do the retrieval. So I think that right time has come now, and we hope you will see the good news very soon.
Wonderful, because there are certain suggestions on this which can be made, especially at NOTTO. You cannot be registered as a center if you don't have a nephrologist, right? If that nephrologist only wants to work half time, there's no reason why other nephrologists cannot be brought in under his so-called, umbrella, and you do it. I mean, it can be. People want to. That's one. So it's a suggestion. I think I spent my whole lifetime trying to drum up business. And we should do everything possible. Second is, now I come to. So thank you very much. Right now, before I take the help of the police, I will ask Dr. Archana how organ allocation is done at Delhi and national level, and what is the compliance which is mandatory to be followed by hospitals for allocation. And then, of course, the obstacles and challenges are huge. So let's talk one by one. How is the organ allocation done at Delhi?
Sir, organ allocation at Delhi, actually NOTTO is playing as a SOTO for Delhi NCR, and of course NOTTO for the national level. So for SOTO level, we do allocation among the hospitals of Delhi and NCR region, which is Noida and Gurgaon. We have a WhatsApp group where the alert come and then we circulate. We have a process which is there on the NOTTO website. You all can check by going and typing allocation in search bar. You will get the allocation criteria for each and every organ. And we mainly follow government to government, private to private. Just to give you a brief about this, whenever there is a donation in a government hospital, the priority goes to a government hospital recipients. Whenever there is a donation in the private hospital, the priority goes to a private hospital recipient. The others are like clinical things where the blood group and the super urgent category is there. But I would say at present, the allocation is very prompt, very transparent.
Can we make a comment here?
Yes.
There is no transplant which is a non-government activity. All transplants are government registered, government monitored, government sponsored, answerable to the government and to the courts, right? Some of them are conducted in government institutions, some of them are conducted in non-government institutions. This divide of government and non-government, I think, is more conceptual, and for whatever reason, organizational, there is no reason why people cannot cross over. For example, I was asked and I was requested, I went and helped RMS do transplants. We started a program, right? So I don't see why other people cannot come over from one to the other. This is a conceptual thing, that this is government, non-government. The kidney does not know whether it is coming from a government hospital or non-government. So can we do something about blurring those lines or moving those lines?
We are working on it. You were there in the meeting in ISOT where we were working on
Yeah,
one nation, one allocation policy. So we are definitely working on it. But as government and private is because I think so that everyone will get a chance to have a disease donation program.
Well, absolutely.
I'll just quickly add. See, if everyone is doing equal amount of work, what you're saying is right. So maybe we are heading now to a place where donations are happening everywhere. If all the work was being done in private hospitals, the donations, then obviously the recipients, people thought they should have more. But I agree with you, it should be a uniform thing. But again, we have this issue as a country that 90% of the work is done in Maharashtra, Tamil Nadu, etc., and the others are not doing much. So the same thing applies. Every hospital is not an organ donor hospital.
Why
so
not?
when we give to them, we should have a little thought.
Why not? Why every government hospital or every medical college should not be a organ retrieval center? Why does it? It is our need. They don't need us. and we are asking them to come to us to be registered. It should be something we say to them, you do it. All medical colleges must have some transplant activity, doesn't matter what. And therefore you have them all declared as organ retrieval centers, and then bring them up. Why not? See, today we have come 20 years ago, 30 years ago, we used to say, can the transplant be done? How do you overcome the rejections? Today you don't talk rejections. You're talking volumes, how many cases to do, what you want to do. So we have come a long way. So I'm just saying conceptually now, you're sitting, all the leaders of thought are sitting here. Why conceptually we are still holding on to this divide of government and non-government? It is a government activity, government inspired, registered, sponsored, everything, answerable to the government. No other field of medicine or surgery is so intricately involved with the law. So it's a conceptual thing. So I request you to look at that, see whether you can blur. Now, I'm not done with you yet. I'm getting my own back with you, right? So what are the obstacles and challenges you face in the allocations of organs?
Main challenges is the mandate of NOTTO was centralized waiting lists, sir, and that is the reason why we were not able to implement it. No government, and we are restricting it to government and private. Once we have a centralized waiting list, we will be able to do the digitalized allocation which we are aiming at, and at that point of time, I think there won't be any barrier of government to government or private to private. It will be as per the waiting list, so the more transparency and accuracy will be there.
Another question which I can ask you, since you are the apex organization, there are a lot of specific helplines and funds available to various centers, to various departments. How do we overcome that?
So the funds and the provisional financial provisions, I would say NOTTO is an apex body for networking. As a networking agency, the finances and the provisions lie with the program, which is National Organ Transplant Program.
And how does a center somewhere approach where he does not have an identifiable person or a table at which he can say, I've done so many donations, I require X amount of funds to continue doing so?
So the center can send the email to us and we will be directing to the right department for the funds.
So ultimately it is people have to come to you, isn't it?
No, if
so
they don't know.
Can we look at this again, that you may be only doing a networking, but you have got a role bigger than that. And I think the role has to be redefined. I'm not saying you should be in a position to sort of emphasize, right? But at the same time, a lot of people will turn to you for questions. And the participation of various centers depends on the fact that they should continue to get the support, which is promised to them.
Definitely. So we
So
do
it is worth
that.
looking at.
We do direct and coordinate among the right department to get that help too.
Yeah. Okay, wonderful. Okay, so that, I would like to thank the police department and ACP Vijay Singh Saab. I have to ask two simple questions. That in the traffic police itself or in the police department itself, what is the awareness about transplantation, organ donation, and movement of organs from road to road, hospital to hospital, major hospitals, airports, now drones? So what is the awareness and what is the process of making this green corridor in cities? Can you predetermine them or do you wait for them case by case?
First of all, good afternoon, everybody. It is my first chance to be a part of such panel. Very learned people are sitting alongside me, having specific knowledge in their field. But I think that everything revolves around the life, and it ends with the death. But there is something here which starts after death, that we can say it organ donation and then transplantation of that. It is a thing which provides life to a dying person, we can simply say. So we take it on a great priority. because it is life-giving opportunity to a person who is hopeless of the life. It is the level of awareness in our department that we treat it as a great sensitivity. The other thing comes when we get a call. We are like ma'am many times approach us for the transportation of this organ, one hospital to another hospital. The technical thing comes the green corridor. Everyone wants to know what is the green corridor. Green corridor is nothing is green corridor, but it is a special way. Just like we provide to a VIP, like our Prime Minister, our President, or any other VIPs. So we choose a way or choose a road which is very having shortest, fastest, and least time taking. We keep in mind that we have to take minimum time to reach the organ from this starting destination to the final destination where it is to be transplanted. We have to make some certain preparation for that. So we take it on highest priority. Suppose it's starting from airport. So we deploy our traffic inspector, who is in charge of this airport, particular airport, and he will lead or pilot this organ or ambulance up to the final destination. It is a case in a single organ system. But last time we were witnessed from Apollo, 3 organs were moved for different locations, not a single organ. It was a challenge for us. We prepared for it. I just because I was the nodal officer for that. Earlier we have dealt with only single transportation, but this time we were having challenge for 3 organs actually. One was going to Medanta, Gurgaon, one was going to RR Hospital, and one was going to West Rohini, Jaipur Golden Hospital. So it was a challenge for us. So first I make some homework. I deputed my 3 local TIs, traffic inspectors, for everyone. We decided that they will go up to Dholakua. After Dholakua, we deputed some other traffic inspector of the further destination. They lead from Dholakua for different locations. So we managed it very. Madam also appreciated it. Some of the members of this field also appreciated, and we were very satisfied that we managed it.
We read about it in the papers, and we are duly grateful that the Delhi police has been so helpful to us, and not only in Delhi, but you have crossed over in the NCR to the various other parts. I have a small question. Suppose your lead pilot or whoever, and the traffic is not opening up in front. What do? Do you have a camera in front which you can later go back and say that you have not?
Actually, we have some preparation before moment. We got information about any transportation well in time, so we make some preparations on the road side. The local staff is being informed accordingly, and we try to close every stretch falling on the main stretch. So we try to make the least traffic on this stretch so that the organ could move smoothly.
You control the traffic lights as well?
Yeah, we control traffic. We make the light manual operating, and moreover, we stop the traffic joining the stretch by sides many times.
Why I'm asking this question is that it's very easy to read the papers, green corridor, but you can imagine the amount of organizational skill, and especially as you said, not one organ, but three ambulances going in three different directions. It must have been a huge challenge. But he's saying it so simply, but the fact of the matter, it must have been somebody's nightmare. So we really owe a great degree of thanks to you, and we continue to want your support in years to come. So thank you very much, sir.
One more thing I would like to describe. When it comes peak hour, actually, last person was to Apollo Hospital, and it was a peak during peak hour. So we had some difficulty, but we managed, however. So the Apollo, when we discharged 3 organs at a time, this was also peak hour. So we have some difficult. Actually, initially when I got information from man that it will be around 3:30, so I was very happy that it will be before peak hour. But when gradually doctors take time, many conditions, and it reached around 7. So we were very conscious about it, how it will be, but we managed.
We are very grateful with you, for you always.
Yeah,
Thank you.
Thank you. Thank you.
I would like to just add that the last, where they made 3 green corridors at the one point of time, because we expected that it will be 3:30, so I informed them 1 hour prior, and all were there on duty from 3:30 till 8:30, because the time was extending half an hour, half an hour, half an hour, and we completed by 8:30. So all were there, and I'm really thankful to all of you.
Thank you. So now my friend Dr. Seth, see, the problem with Dr. Seth is his experience is so vast, and he has created organizations not once, but he's for the armed forces, then with Fortis, then with the other hospital, with somebody else. I don't know how many hospitals he goes around, and then he comes out with names also. Aorta, a fort, and now you come out with something else. You know, these are amazing how he does this. So we would like to have a little more time to pick your brains. So what are the obstacles and challenges in implementing these programs or getting them going with an organization which is so far doing the transplant but doesn't have a program of this kind? So when you initiate, how do you get it going?
Thank you, Jawari sir. Always a pleasure. So yes, experience in the government hospitals and now to private organizations. Few things I would share. But number one, we all have to remember that organ donation doesn't happen on its own. You need someone to be constantly pushing it. And unless the push starts from the top, organ donation is not going to happen. The felt need has to be there, which the head of the institution or the chief CEO of Fortis or CEO of Banipal or the health minister, somebody has to say why this is not happening. Please do it. So the first thing is the felt need. And you know, for the last 10 years, we have been holding national meets. We call experts from Spain, Australia. We were doing it in Fortis all the time. And they used to say something very interesting. So the CEO of a hospital chain was told, "Sir, do you know why you do not get organ donations in your organization? Where is your department of organ donation?" He says, "You have no department. You have surgery, you have medicine, critical care. You have no department of organ donation. In Spain, we have the OPO in every hospital." So this is what we have tried to create, that we made aorta the armed forces organ retrieval. That became the department for all service hospitals. We got the army chief, everybody to pledge and come downwards. We made Fort for 10 years. Dr. Rahul was working, we worked together, Fortis organ retrieval and transplant. The CEO pledged. And I think Fortis was our only organization where we had, say, 17,000 people, and every visiting card had an organ donation message in it. So this is how it starts from the top and then percolates down. We all come to work in the morning, patient care, go back home. Nobody thinks, Aaj Angdan ka kya hua? So you need that person, you need that trigger in every organization. Only then it happens.
Does it have to be an identifiable person, or does it have to be a process in the hospital, starting maybe from the ICU or from the clinician who is in charge of the liver or the heart. For example, the heart doctor is looking at me. There's a big problem because the cardiologists and the cardiac surgeons somehow seem to be on different planets. Similarly, with other places, you don't have that kind of cardiac or hepatic ICU kind of,
Yeah.
OPD. Kidneys still, there is some dialogue. So
That, I think that's an important question because I've seen it in the last 20 years. This is how it goes, we have various levels of hospitals. How it starts, organ donation, is with a felt need. Somebody says, okay, we want to do a heart transplant. So he becomes the trigger for that particular hospital. Somebody wants to do a kidney transplant. He is the one who pushes. So we have clinicians from one of the transplant teams trying to push everyone else to do it. That is the first stage. The second stage comes where the organization gets involved in it. Or the third stage comes where, with a constant process of daily monitoring, we are picking up organ donors early. We start talking to the family. We start training people. We had 18 Fortis hospitals. We had constant meetings with all of them, and it becomes a part of the system. And finally, it becomes like a hospital where Dr. Rahul Pandit is, where it is self-driven, without any external inputs required, from within the critical care system of that hospital. So I think 99% of our hospitals at a stage where we all have been pushing. Some are at a stage where the organization wants it, so the critical care, some of them reluctantly are into it. But the third stage, which I think all of us should aim for, is the stage where Dr. Rahul brought Fortis Hospital in Mulund, Delhi, in Mulund, Mumbai, where he did maybe 100 organ donations single-handedly.
So full marks to you, Dr. Seth, and our thanks, because you have led the way in how an organization can be involved. Most places, the organizations are either oblivious or definitely not interested. So you have done it in government and non-government institutions. I think we owe a great debt of thanks to you. And I am informed that I stand between you and your lunch 5 minutes from now. So I have got, she told me in between that you can take 10 minutes more. So 5 minutes from now, the food is going to be served? Okay, right. So can we ask to have some questions from the audience, especially in the back if you are awake? Yeah? Come on, some of you, we are not that intelligent. We have not made such profound statements. Any questions? Come on. Okay. Reluctantly. But these answers we will not be able to give. From intelligent people, serious.
No, I thank Delhi Police for serving us so well. But I think we need to think widely. Now is the time when we need to think of drones. Unfortunately, Delhi happens to be a no-fly zone for the drones. We have a e-Sanjeevani project ongoing in NCH Hajjar, and we have been during the COVID period, we did the trial of the drones. It's in place, the company people are there, and I am actually trying to push in the drone program for the organ transplants. And trust me, it is going to be a game changer for our country. People have done it in other nations very well. It's been happening in Sydney, it's been happening in states, and probably many other stakeholders are there. So I have everything in place for me. All I need is the permission to do that. So if you have your problem of 3 organs, 3 different directions में कैसे गए, कितने लोगों को लगाया, कितने लोगों का traffic रुका, it's not easy. So all this problem can be taken care of just with the use of drones. Regarding your issue which you discussed about public and the private organ distribution, I have got serious objections to that. I think it should be in the waiting list period. I have serious problems in the paired organs, like in All India Institute of Medical Sciences. Paired kidneys, one kidney goes to a person who is waiting for the kidney for 5 years. And the second kidney, it goes to whom? The person who is registered 1 week back. That's insane. It's something which is to be addressed very urgently. It has to be on the priority of the how sick the person is like and how long is the waiting list. Number 1. Number 2, all the stakeholders, they need to start contributing. Come on, you get food only when you work for it. I mean, you just can't be a transplantation center all the time. You have to be a retrieval center also. I did my training from RML, but How many donations are happening from RML Hospital? It's the busiest trauma center. How many donations are happening from Safdarjung Hospital? Busiest trauma center. Patients don't die there. They do die. But where is the initiative? Unless and until we start doing that, we have to be self-sufficient for the organ donation program to run. Otherwise, it's going to remain like that. Few institutes. Why on earth the donations are just 700 to 800 in number in our country for the last 40 years? 30 years. 1994 we started the program. 30 years it has been. India has never crossed a magic figure of 1,000 organ donors per year. Why? There is no initiative from the clinicians.
Do you think it will help if we have a paid post for people in these hospitals identified as people who are going to encourage transplant? Whatever heading you give to them.
So we do have some posts, so-called dummy coordinators. If somebody is not trained to do the program, I mean, there are some coordinators, I know, we don't talk about the role of coordinators, the counselors. If we have got good grief counselors, they can really convert a no to a yes. I mean, we spend so much of time, 3 days, 4 days for conversion of an organ, and all we get to hear is no. That's it.
Sir, I would take your point forward, and there are very many people sitting here who can take it, that in Spain, we keep talking about it. The transplant coordinator is a very senior consultant who can bring all OT lists to a halt because the next patient coming in is a transplant. Here, we have got the junior most people as transplant coordinators when we started. Maybe the time has now come to create a cadre of now those who are more senior and then bring in, when we started, they were like the house officers. Now we require specialists who can actually have that seniority, who can bring the OT list to a halt if there's a transplant required. Now, it's a suggestion for you. You're the one who can push it forward. Yeah?
Regarding this public-private divide, I think it should not be there. Because
we agree.
In Kerala, at least, I can only speak from the Kerala experience. Wherever the donation happens, one kidney goes to a government hospital. So, the liver transplant has not actually taken off in government. It is happening. But if there is a single list, it will be more kind of transparent and respected.
Agreed.
I just want to add a comment on having people paid to do a job for organ donation. And the first thing which people need to realize, doctors need to realize is that just as we are legally obliged to declare a patient dead after the heart stops, you are legally obliged to declare a patient dead when the brain stops. And that is our core job. That has got nothing to do with me getting paid for it or not. And that is what we should be doing. So we need to decouple the brain dead and we need to decouple organ donation. Once the brain dead is declared, you can have a donor coordinator. I take that job myself, that I should be actually talking about organ donation as well, but people may not agree to it. In that case, you can have organ donor coordinator or somebody who is specialized into that communication and can take it forward. You could pay that person. I have worked in Sydney where I was a consultant, midwife as a concept, where an intensivist or any other specialist in the hospital was paid 0.5% of their salary through that budget. I can't do that in a hospital. I've got 5 intensivists. We've got 90 patients. We had 5 intensivists. We had 25 patients there in the ICU. So if I have to allocate one intensivist for just 0.5 job to do organ donor coordination, we won't be able to do justice in our country that way. So I think the best way is to actually have donor coordinators, senior person, as you said, not doctors, but the doctor should realize that it is their duty to declare a patient dead. No two ways about it. You can't get paid for that. It is our duty to do it.
Can I make a comment? Dr. Pandit, one thing to say to you is, see, not everybody is a Dr. Rahul Pandit. And the kind of motivation you generate in you, your colleagues, in your juniors is not easy. Most people here, just kind of junoon hai. We people, when we came into transplants, there were no guidelines, there was nothing. They were all a bit touched in the head. Now the next generation requires it as a profession. So maybe a little more organized cadre of people coming in, right? Which is again, the director notice nodding his head. So maybe it is something we need to look at, that the time has come. Work has increased to a level that we have a more organized cadre. This is a throwaway thought. Yeah. Dr. Mathur, please. Thank you, Dr. Pandit.
Yeah. So there are 2 things. One is this Spanish model. Okay. I'm very
much against and critical of it. See, the Spanish model is different, where the healthcare is in the government sector. It's not totally dependent on the private sector. Let's understand that India is different. We have a public sector, we have private sector. So we cannot copy paste that. Okay. The volunteerism is important. So what we are talking about, this public-private divide, as far as the list is concerned, Maharashtra we maintain single list. Okay. As a matter of fact, all the public hospitals are beneficiary of donations, which are maximally 90% are happening in the private sector. Okay. So the organs are shared with the public sector. So they are the beneficiary. So even if they don't contribute, they get the organ. So the patient gets the organ. So there should not be this model which has been copied by NOTTO is the Tamil Nadu model, where there was divide between the public hospital and the private hospitals. And that can be very well manipulated. And it was done. I don't want to name the hospital, but it was very well done, where you shift the donors from smaller public hospitals, okay, by different dubious means, get to the private, declare them, and then have the donations, which in Maharashtra we don't allow. There is no shifting from a smaller. If it is to be done, it will be done by the organization. If, like what was done, I think here, 2 days or 3 days back, that is done by the organization. So it is a controlled situation. There is no freebie. About this Spanish model of labeling somebody as an organ procurement in charge. Dr. Rahul Pandit knows that we have got an intensive care committee of the whole city, when all the hospitals intensivists are a part of it. And we put a proposal, okay, will you like to be labeled as a transplant procurement director or something like that? And we were negotiating with their CEOs that you should pay extra for them. You know what they said? If we do that, the patients and their relatives will lose faith in us. They will see us as organ seekers. Okay, and that will bring the bad reputation to the whole program. The whole voluntary donation which is happening in this country will stop. What happened in Kerala? Kerala was a classical example where in 2016 they were flying like this and then they fell like this. Isn't it? I'm not wrong. Tamil Nadu.
Sir,
we talk about Tamil Nadu model.
Sir, we are straying from the subject.
No. So we have to be very careful when we are recommending these things.
Sir, I am standing between lunch and the
Sir,
audience.
I'll just like to make a small comment. I'll just like to make a small comment regarding why this is not happening. Now, this is exactly the reason. We had a patient last week in our ICU. He had an anaphylactic shock, hypoxic injury, was with us on the verge of being declared brainstem death. I was the intensivist there, and I could only certainly mention that, okay, now this is the time that his brain is not going to recover, and we should consider, because his brother was his nurse who had provided the initial CPR on the bedside to that patient. Now, the thing is, I couldn't say it strongly because the other relatives which are standing there looked at me suspiciously. Now, that is exactly the thing that awareness has to be brought about.
Sir,
And
I'm sorry to come in here. Obviously, there are sides to and many facets of the same issue.
True, sir.
Question is, there are two people here. One is our director, Notto. Behind them, students. I will not let you people have lunch unless one of you asks me a question. Yes, somebody from the back has to ask a question. Anybody? Any question? No question at all? How can that? That's wonderful. Come on. Come on. Some question, any question. Otherwise, no lunch. And we'll round it off with the director afterwards to make a comment.
So thank you very much for this nice discussion. It is really insightful and we get a lot of knowledge. As a physician, we are ready to do what you want us to do, but we do not have transplant coordinators, we do not have the right infrastructure, maybe from the administration side. So I would urge NOTTO rather, as you rightly said, if you are the takers, and we are the givers, then the takers have to come to the givers, not the other way around. Thank you.
Point. We'll clap on that. I agree with you 100%. Now the final word from the director NOTTO. Thank you, sir.
See, we are now moving. Look at the panel of the from the private, from the government, from the police. Our consultant is sitting there, intensivist is sitting there, CTUS surgeon is there. So now what we are moving is, let us move out from our silos and work as a team. We cannot say that these are givers and those are takers. No, let us work as a team. So now look at Lady Harding Hospital has never done any transplant. There is still not a facility to do it. RML Hospital person is sitting here who has done the first cardiac transplant. From the Safdarjung Hospital, representative is there who is doing the renal transplant. Here is the person who has created so many liver transplant units. So answer is here, we all need to work as a team. We need not create these silos, and as Dr. Saab has said, enough time has passed. Now we have learned our lessons. It is not that since 1994, transplantation was done even earlier before. So now we have learned our lesson. Let us sit, let us decide. Now path is clear. We need to work as a team. We need to create the systems which is all inclusive. It is for a nation. We are now moving towards a one nation policy. Unless or until it is one nation policy, we will not be moving forward. Then we have to hold the hand of each other rather than saying that you have to do this, you have to do that. We have to hold the hand of each other. See, it's a skill. Transplantation is a skill. It's a very skillful business. It's a very skillful art. So the till now, what our experience is, most of the transplants has been done in few centers. Most of them are in the private sector and few of them are in the government sector. So we need to create the partnerships between those who have walked a distance and reached at a place and those who are yet to start and those have just started. So we are on that track. Things are moving on as far as government is concerned. I can assure you, in the morning we were discussing about that brainstem death, definition of death. We are moving on that. There should be a single definition of death. We are moving towards that. I hope that in the coming few months we will be coming up with that unified definition of death. Then as far as who should be leading that process of transplantation, I will say that clinicians are the best people. I understand, see, a person who is intensivist, who is looking, giving the care to the patient, is the best person to whom that family or the attendants have the faith. If somebody from the background comes and say, I am here for the organ donation, I think it will not work in that way. Yes, counseling is a specialized job that we understand. It is not everybody's cup of tea. So there should be a cadre, as sir have said, there should be a cadre which should be trained cadre to do this task as a team, a part of the team, intensivist, and that team member should be the party to it. So we are looking at it, and I hope, and with the support of you all, we will be moving in the right direction. And sir, that 1,000 figure is not that far. Thank you.
So thank you everyone. And I think we are at the last stage of this session. Yeah. So over to you. Thank you.
Thank you so much, sir and ma'am. I'm sure that with this galaxy of intellectuals, we can never get enough. I would like to request Dr. Krishnan Kumar, Director NOTTO, and Professor Dr. Virendra Kumar, Director LHMC, to kindly come up on stage to felicitate our guests with the token of our gratitude.
Thank you very much, sir.
बिल्कुल
हाँ फोटोग्राफ ले लेते हैं सर। अब जगह चेंज
Thank you, everyone. Lunch is served at the first floor of the same building. We request everyone to kindly proceed for lunch. I repeat, lunch is served at the first floor of the same building. I request everyone to kindly proceed for lunch and please report back to the venue at 2:40 p.m. sharp. Thank you.